distribution, which might also influence negatively the long-term results of this. In summary, if one doesn't do imaging, we are likely to underestimate calcium with an increased likelihood of improper vessel preparation, with underexpansion, complications, longer procedures, malapposition, and more stents being required. The options that we have are rotablation, orbital atherectomy, intravascular lithotripsy, laser-based techniques, and balloon-based techniques. But it's important not to compartmentalize these treatment options, and it's important to use all these techniques in combination and use our decisions based on imaging. And that's what I'm going to show with the help of the examples, as this has already been seen that cardiac death, MI, target lesion revascularization, and MACE are higher in the combined pooled data for calcified lesions, which is drawn from Horizon CMI and acute coronary calcium. Now, as far as the relevance of DES expansion, this also has been spoken of. We have a failure of delivery with a damage to the DES polymer and under expansion, which leads to more ISR. Now, what about detection? Coronary angiogram detects only 38% of calcium. IVUS is highly specific with a 90% specificity and 100% sensitivity, 90% sensitivity and 100% specificity, but it can miss isolated microcalcification, and it does not define depth well. The calcium arc is defined well, and that is what used to be used earlier to decide whether we need to modify the plaque or otherwise. OCT, which has now been used for a decade and a half, shows the area, the thickness, the length, and the 3D volume of calcium distribution. It shows us the arch, the thickness, and calcific longitudinal length with points for all these, and more than 4 points means means an extremely high risk of underexpansion as compared to anybody with less than 2 points. The treatment options we have already spoken of. The balloon dilatation techniques include a conventional non-compliant balloon, the scoring balloon, the cutting balloon, and the new kid on the block, that is the intravascular lithotripsy. The plaque modification tools are rotablation, orbital atherectomy, which is not yet available in India, and laser, which is just about become available in some centers in India. Now, standard balloons are semi-compliant. Nominal is typically 6 to 10. Non-compliant balloons are supposed to increase very little in diameter as we can go up on the pressures. The newer and the modification of plaque can be done by the flextome cutting balloon, which has atherotomes fixed on the surface with a 6, 10, and 15 millimeter working length, with a 020 or 018 entry profile, depending on which version one uses, with 5 millimeter blades, which are mounted on the tip. There is also the scoring balloon, which has a nitinol wire wrapped around a normal balloon, and this actually increases the scoring force and increases the stretch on the vessel, although how much it actually modifies the plaque is controversial. The OPN NC ultra high pressure balloon is a modification device with a low entry profile. It has a double layer and can go up to pressures, usually up to 35 is what they recommend, but people have gone to 45 and 50 as well. This has a much lesser risk of dissection and perforation, and this has a much lesser risk of not being able to dilate the lesion completely. It gives a predictable amount of pressure at the lesion without uncontrolled radial and longitudinal growth, although the thickness of the balloon makes it sometimes a little difficult to deliver. What happened to our cases? What combination did we use? This was our first case. This is what we did. We wired the LED and the diagonal. We did a little balloon dilatation and did an imaging. And what did we find on the imaging? There was concentric calcium everywhere. There was thick, deep calcium, as one can see in the second image. There was thin, deep calcium as well. There were also lipid plaques. And this is also L6 ostium, which showed us a calcified nodule right at the ostium, which makes it a little difficult to modify that segment without changing the morphology of the ostial circumflex. So we used an IVL balloon, both in the distal and opposite the diagonal, and then after that repeated the OCT run. And you can see the cracks in the calcium, which are very, very nice and very gratifying, because this means that we are going to get a good stent expansion in this particular lesion. And after that, we were able to deliver one long balloon and then do another OCT at the end of post-dilatation with a conventional NC balloon. And that's what we got. And you can see the lumen before, after the IVL, and after the stenting with a perfectly acceptable result. Same thing we did for the RCA. Again, it showed a combination of thick and thin calcium with a healed plaque and a dissection following our ballooning. And after the stenting, we had a very good OCT and angiographic result. The second case, this is our patient who had the subtotal occlusion of the distal left main. And we went ahead with first putting an XTR, which is our favored wire for crossing difficult lesions. put in a 1.5 millimeter burr, and then burred the entire left main to the LED in segments sequentially and simultaneously, ending up with a polishing run with a deceleration of less than 5,000. Peck and polish, check that there is no perforation at the end, then put in a wire into the ramus, dilate the left main and the LED with a angioscalp and a cutting balloon, used a long NC balloon to further modify the plaque, delivered a long stent, optimized it, did a proximal optimization with a high pressure NC balloon, recrossed the OM, did a small balloon dilatation because we didn't feel that there was any need for a stent, looked at our stent expansion. Since this patient had some azotemia as well, we didn't do an OCT for him. The IVUS would not have been of very, very great use because we felt that the depth would not have shown as much. This is what we got at the end, and the patient is about a year and a half now post, and he's doing very well. The third case, the 86-year-old male with crescendo angina who had the left main bifurcation. There was a large thrombus, so were not comfortable doing a rotablation. So we had both the OPN and the cutting balloon available with us, and that's what we did. We first wired both with an IVP in place, dilated after a cutting balloon with the OPN, both the LED and the circumflex. This is our post-balloon angiogram. Then delivered a stent from the left main into the LED, crossed that and did a tap with a small stent into the circumflex with a final kiss. And that's what we got at the end. And the patient again is doing well. He is now 2 years post and he's doing absolutely well. This is a simple algorithm that one uses for crossing of the balloon. Either it crosses with the balloon or it doesn't cross. If it crosses, we pre-dilate and perform an imaging. If there is significant deep calcium, the best option is a lithoplasty or a lithotripsy balloon. If not, the superficial calcium, one can do non-compliant balloon and look at optimal balloon expansion. If you don't have, we go back to the lithotripsy. If there is no deep calcium and mostly superficial calcium, rotational atherectomy and orbital atherectomy are the options. Once we get a balloon expansion, one can place a stent. If one is unable to cross with a microcatheter, one can attempt a direct wiring with a rotablation. If one is not able to do a direct wiring, then the option remains only laser. And if one is able to do, then rotational atherectomy or orbital atherectomy are both options. Again, put in a non-compliant balloon, see if we get an optimal expansion, and then do a lithoplasty. In our lab, what we do is, now in patients who can tolerate it, after doing the rotablation, we put in a workhorse wire beside it and then look to see whether we have got a good cut of the calcium. If the calcium cut is good, you can remove the rotablation wire and complete the procedure with an NC balloon. If it's not, remove the workhorse wire and go back in with a slightly bigger burr or at lower speeds. The important thing is to use all the techniques in combination, and all decisions need to be based on imaging, as we have tried to show. The take-home points for us are calcified lesions are no more benign. They're difficult to deliver with respect to hardware. Under-expansion is a significant risk. Imaging has changed the way we approach calcium in the coronary tree. Aim is to get the best result with a combination of all the available techniques without compromising safety. We now have multiple tools. Superficial with less than 500 microns, balloon-based techniques may be adequate. Thicker calcium needs plaque modification, but one needs to be a little flexible and have all the techniques available to use. For deep calcium and thick calcium, IVL is probably the best. Sometimes one needs to do a preceding rotablation to allow the IVL balloon to get delivered. Thank you for your attention, and should be glad to take any questions.
Thanks, Ajay, for your comprehensive presentation on plaque modification by various hardware in a calcified lesion. Now, how do you decide about use of rota versus IVL in your calcified case? Like in your second case, you did use rota for the left main. Problem with the rota is you can put only a single wire across, which you did place for the LED. While IVL, you can very well place a wire both for the L6 and the LED and go F4. So in your practice, how do you decide about the using a rota versus IVL?
So, sir, rotablation, as far as we are concerned, for bifurcation, I think that we'll take that question in two parts. Rotablation with bifurcation, very rarely have we had the problem of not being able to cross with the second wire. Once you rotablate the main vessel, there is absolutely no problem. Even if you lose the second wire, there is no problem at all. In fact, we don't use a second wire at all. In certain situations where one is really worried about losing the second wire, sometimes we used to be a little scared. But after 4 or 5 years, we are absolutely confident there will never be any problem in crossing into the side branch. Only thing, the precaution that we take, suppose we have decided to rotablate both the LED and the circumflex. Usually we will do the circumflex first before the LED. because that ensures that it's usually easier to go from the left main into the LED. I mean, this is a general rule, but normally we will rotablate the more difficult branch. It's also possible that one can use two guides, or one can use a guide liner with a 1.25 burr, protect one of the circulations and then do the rotablation. But that is only feasible if one is delivering the burr beyond the bifurcation. It's not really a great idea when one is doing a left main bifurcation, which is the major place where we're really worried about expansion. The other segments of the coronary tree, the mid LAD and the circumflex, is a particularly tricky part as far as rotablation is concerned. And we often do it in segments. We do it burr by burr, and the guide liner is an excellent technique to try and take away the proximal bend of the circumflex. If one is able to deliver the guide liner beyond that, all our wire bias and the fear of the burr exiting the circumflex is not a problem. As far as the decision, I tried to show that imaging is what helps us to make the decision. If one has superficial calcium, I would actually go with rotablation first, test with the balloon. If we're getting an expansion, go back in. If it is deep, thick calcium, I would prefer to try and deliver the IVL either at the beginning or definitely at the end before delivering the stent.
Very nice. Arvind, any comment? Dr. Akasaga, any comment of your side regarding, say, IVS and OCT, and means IVS not able to have an idea about the total penetration of the calcium, 500 versus 900 micron, and is it going to impact the end result or stent expansion in the calcified lesion vis-a-vis OCT?
Yeah, right. Yeah, as Shawik said, the OCT may have the advantage to identify the calcium itself, and also we can measure the thickness and distribution very well compared with IVAS. But if the calcium is very deep, because of the penetration depths, OCT cannot detect. Therefore, we try to use the advantage of each imaging device when we decide how to treat the lesion. And I completely agree with his opinion, right? In the case with superficial calc, we can do either rotablator or orbital atherectomy. And finally, the calcium is very thick, especially in deep. Shockwave might be very effective.
Sir, you have to be somewhat louder. You are not audible. Okay, fine. So let me move to the
Dr. Rajesh. Just single
please,
comment.
Arvind.
Suppose a patient, Dr. Swami, a patient on coronary angio shows moderate to severe calcification, and we are unable to negotiate the balloon. And in this situation, we are taking the help of microcatheter. Even then, the wire is not crossing. And suppose if we are putting in Viper wire, suppose rota wire is also not, because this caliber is of this Viper and rota, they are totally different. Now, if we are able to cross with Viper wire, now this patient requires on the Viper wire, we can do orbital atherectomy. Is it available in our country, or should we go for rotational atherectomy?
Orbital atherectomy is not yet available, and orbital atherectomy means that our orbital atherectome has to actually get delivered. So the advantage of the rota is once the wire crosses, the burr will cross. For orbital atherectomy, the entire device has to cross because it's about maximizing the area. So, I mean, in that sense, I feel that rota actually has a benefit. The only place where the orbital atherectomy scores is in patients with calcium nodules. And that also we are working on a strategy with rotablation in which we actually burr once and then balloon dilate and then burr again. And I think that's the best option that we have in India in the absence of the orbital atherectomy. And I hope that answers your question. If the Viper wire crosses and your rota wire is not able to cross, most of the while we are able to jam a small microcatheter now with the Corsair Plus. It has a beautiful profile, and you can actually jam the Corsair Plus and deliver the rota wire distal to it. Once the rota wire has gone, all our problems are solved. But very often, sometimes because of the bend in the vessel and with very, very tortuous calcium, with a little bit of tortuosity, one can deliver a very small 1.0 balloon, which is a sapphire balloon, and make a small space and then take the microcatheter across. Because the whole point is that we are going to modify the plaque enough for us to be able to deliver the balloons to create a good enough lumen. And, it is no defeat. Sometimes you have to back off and say, okay, this patient goes for surgery. I mean, the safety is the most important thing. We do, in situations as we become more confident, we do push the envelope a little bit, but it's important to be aware of the limitations.
Thank you, Ajay. And now let me go for the next presentation by Dr. Pratap, a good friend of mine. He's the Chief Intervention Cardiologist and Chairman of Matrina Group of Hospital. He is pioneer in CTO intervention in India. He has performed around 12,000 CTO with almost 10%, which is been done retrogradely. So Dr. Pratap is going to talk about chronic total occlusion, keeping the front and back doors open. So both antegrade and retrograde approach for CTO. Pratap, please.
My talk is basically on a CTO intervention, and I'm just, since it is a calcified total package, I'm just talking on the rotablation and CTO. This actually, CTO is actually very difficult lead. Basically, in a calcium in a CTO makes a CTO intervention very tough. Crossing CTO when the distal vessels are not seen is very difficult. Calcium can be tackled by an NC balloon, cutting balloon, and atherectomy measures. By doing a rotational atherectomy, lesion should be crossed by a rotowire. Rotowire can be taken only when the microcatheter, corsair, or a tonus cross the lesion. Sometimes CTO can be crossed by a rotowire only. If the rotowire does not cross, then it will become a real challenge. Sometimes retrograde crossing of the lesion will help in this regard. I'll be showing you only 3 cases. With this patient is an ischemic cardiomyopathy with 28% EF, anemic patient, ESRD on 2/7, family history of CAD. This is an angiogram. A 58-year-old man, middle AD is totally occluded, 40 to 50% plaque in the proximal. We thought it is very simple lesion, but it is not crossed. Basically, the antegrade wire we tried, but the wire never crossed. Wire is only going only to the diagonal. It's never different wires, Gaia third. I'm telling you up to the Gaia third, and the Miracle 6 also did not cross. So what I tried is actually the fine cross could not cross the lesion. So the guide wire could not be retrieved at all into the LAD. So what we did is actually, we decided to go retrograde. So the corsair with the cyan black is gone. You can see the wire going up. Retrograde with the SUO3 wire, and the wire reached the distally, actually SUO3 crossed, and we reached up to that point. Again, there's a problem. Here it is not going up. So antegrade is actually Miracle 6 wire. 1.25 into 10 balloon is also not crossing. So what is actually, we are stuck there. So the antegrade actually having a corsair and tonus we can try, but nothing is crossing down. So the corsair, we actually just keeping the corsair, and we took a rotowire into the diagonal. Confirm the rotowire by the retrograde injection. We used a 1.25 rotobar into the diagonal. Then it went up to 180,000 RPM with keeping the lesion was opened up. Then we crossed easily with the Phil-Revsey wire antegrade. Then we finished with 1.25, 2 into 10. Then subsequently we put a wire into the diagonal. We did 2.75, 38 resolute integrity. And finally, this is the result. The case number 2 is a 45-year-old male with a PTC and stenting done earlier, which actually was all the stents are patent in the LAD part. The lesion tried to cross with the Phil-Revsey, Gaia second, Phil-Revsey, Miracle 6, also with the balloon support, failed to cross in the RCA. So we actually decided to go corsair with the Phil-Revsey and then Phil-Revsey, cross the septal channels. We went to the septal channels, corsair could not cross. See, that's actually the wire is there. But fine cross crossed. Once the fine cross crossed, XTR is not crossed, but the Gaia second crossed the lesion. Once the Gaia second crossed the lesion, we actually, Gaia could not be externalized. We use a 6 French guide cella into the Phil-Revsey and trap the wire into the guide cella. So through the guide cella in antegrade, we took the wire up. The antegrade wire is not crossed. Retrograde actually went into the guide cella. So the fine cross pushed into that, into the guide cella, then exchange to RG3 wire. Once the RG3 wire came, basically a 1.25 into Tasuna balloon crossed. But Tasuna also did not cross. what we did is actually a channel dilator was used in the proximal part through the RG3 wire. That is actually RG3 antigrade. So we actually used the retrograde wire as the channel dilator. We used a 1.25 into 10, 1.5 into 10, nothing happened. So lesion could not be opened at all. What the field rep see and antigrade. Now with this balloon dilatation, we could cross the field rep see wire antigrade. So the balloon through the antigrade, again nothing happened. So what we did is actually we exchanged the wire to rotor wire. We used the rotor wire and 1.5 rotor antigrade now. So we used a 180,000 RPM, 2.5 balloon used, a promise linear stent with two help of guide cell reached, and wire could not reach the PLV. PLV could not be crossed. So we decided to stent into the PDA. Shifted in a stable patient, and doctor and the patient tried 3 hours of intervention. After 2 hours, the patient got severe chest pain. We saw the resistant thrombosis. But the stent was patent and the proximal part was not opened up. We put another stent in the proximal part. And residual lesion was like this. But we could see that the PLV is not at all well opened up. We finished the case. After 6 months, a routine CAG shows a significant disease in PDA and PLV. So we decided to do a PCA. You can see the PDA PLV. What we did is actually this time we crossed the wire. Wire crossed into the PLV. This is after 6 months. We opened up balloon dilatation, proximal opening, balloon dilatation, proximal dilatation. We balloon dilated in the PLV part, opened up. We opened the PLV also. You can see the balloon dilatation, multiple wires used. One more stent into the PDA, a PLV branch. This is the final result we created out of that. Finally, we created a result like this. This was the final result created after this. This is actually the second procedure done. The patient 3 is a post-cabbage patient with a CKD. Creatinine was 1.9 to 2.1. Angio done in 2015. Because of the angina and advised to do a PCI, they took a second opinion and told that because of the high creatinine, not to do anything. They used a multiple anti-angina. This was the angiogram done. A significant lesion in the ostial part of the circumflex. So what they did is nothing done. Now the patient came to me with a refractory angina with the angiogram showing nothing down. So we tried to cross with keeping the earlier angiogram, tried to cross the field rep wire, not crossed. We tried with an XTR wire. You can see that XTR wire crossed the lesion blindly. Blindly with an understanding what was the lesion earlier seen. This is actually by seeing the previous angiogram, keeping the monitor on the side, then I crossed the lesion with total blindness. After crossing that, I tried everything, 1.25 balloon, Tornus, nothing would cross. So what we decided is we exchanged to a fine cross, but fine cross also did not come. Keeping the fine cross in the proximal part, I tried to cross rotor wire. This was the question asked last time. Actually, we crossed the rotor wire, which keeping that. We used a 1.25 rotor bar, but 180,000 at most. That also not crossed. But the proximal part was created a heating in that. Then we crossed with a 1.5 millimeter balloon, then 2.5, 3 millimeter balloon. We used a 3 into 18 Zions expedition stent and a post dilatation with a 3.5 balloon, and this was the result. So what I actually wanted to tell you, CTO lesions can be crossed antegrade with multiple choices. You may require a rotabation that always do a rota when your wire is deeply in the vessel, which should be checked by retrograde. If it is not crossed, you can go retrograde, and through the retrograde wire, you can do a rotabation. A retrograde wire can be a rota wire or an RG3 wire, then do small dilatation and come. The third situation is that we can even do a balloon dilatation in the proximal part, blindly also can do and finish the case. These are the 3 cases I am showing. This is Thank you very much, Rajesh.
Thank you, Pratap, for this. All the three cases have shown a great technical skills and expertise of a great operator like Pratap is. Very nice. Case number 2, distal RCA did show some residual stenosis even after doing the rota ablation. Any comment about that part? Who had
No,
next stent
actually,
thrombosis?
no. The stent thrombus was not there, Rajesh. Basically, the patient, the proximal part was not opened up very well. So the patient came with a chest pain after 2 hours. Then we could understand that the proximal part of the RCA was not covered very well. So we put one more stent there. That is in the same day of operation. So that it took nearly 3.5 hours of intervention. So we decided not to do anything in the PDA, PLV, which was diffusely diseased. After 6 months, I called him for a re-checkup and then did the intervention again. Then I opened the PLV and finished the case. So actually, that's a long procedure. Initially 3.5 hours in one day. Then after 6 months, we did the PLV opening up.
Dr. Arvind?
Dr. Rajesh, you have rightly asked that in the distal part of RCA, definitely even in the final shot, we had some residual lesion. Did this IVUS or OCT IVUS that showed that it was significant lesion?
No, actually, Arvind, I did not do I was on that day. Basically, it is a C2 intervention. After some time, the radiation exposure, the contrast usage, there should be, you have to stop the procedure after some time. These are the procedures where when you do antegrade try failed, you go retrograde and try. There is a contrast limit as well as the radiation limit where you limit the procedures of CTO. That is actually the limitation of CTO intervention as such.
Okay,
thank you, Pratap. And let me ask the next presenter, Dr. Himanshu Gupta. Himanshu is working as an assistant professor at the Department of Cardiology at PGIMER, Chandigarh. He is going to present the case about the management of complex calcified lesions. Himanshu, please. Okay. Rakin. So let me invite Dr. Rakinder for the time being till the Himanshu is ready to go for his presentation. Dr. Okay. Dr. Akasaka. Yes. So Dr. Akasaka is graduated from Wakayama Medical University in 1982 and finished his residency at Kobe City Medical Center, General Hospital. From 1989, he has been devoted to the clinical research, working on OCT and coronary physiology. He has published many papers regarding coronary imaging using OCT in addition to coronary physiology research. It was privilege of the Department of Cardiology, PGI Chandigarh, to work with him, and in collaboration with him, we have published a paper on OCT in peripheral arterial disease in European Heart Journal as well. So Dr. Akasaka, please, is going to talk about imaging in calcified lesion. How do I plan my procedure? Dr. Akasaka.
Wait a moment. I try to share my slide. Yes. No, difficult to get the slide. Right. You can see my slide.
Your voice should be somewhat louder, Dr. Akasaka.
Yes. I cannot share my slide. Wait a moment. Okay. Wait a moment. Yes. From the first, yes. Right. You can see, right?
Yes, we can see.
Okay. Today my talk is the management of calcified lesions. Yes. This is my disclosure slide. And as you know, there are many modalities to identify the calcium, but the intracoronary imaging is very sensitive. Within intracoronary imaging, as you know, compared with IVUS, OCT is an advantage, right? This is the comparison.
Dr. Akasaka, you are not audible.
Okay. You cannot hear well.
Yes, that's right.
Okay, I try to do my best. Wait a moment. Can you hear me?
Yeah, it's somewhat better. You just adjust your mic, I think.
Okay.
It's better now.
Okay.
It's more better.
Okay. I try to
It's
do
fine
my...
now. It's fine
Okay.
now.
Okay. Right.
You can go ahead.
So, yes. This is a comparison data between OCT and IBUS, right? There are advantage and disadvantage in each modalities. But before PCI, if you use an OCT, OCT might have some advantage as shown in this slide. But this is a reality. Compared with OCT, IBUS should be much more sensitive because of the penetration depth. The penetration of OCT is a little bit shallow, therefore deep calcium cannot be identified by OCT. However, at the time of the treatment, OCT may have some advantage because we can identify the thickness and distribution and the position of the calcium very well, especially the superficial calcium, right? Why we focus on the calcium? This is one of the data compared with the severe calcification. If there are no calcification, the result is much better as shown in this slide, right? Even in hard endpoint. This also another data comparison between a severe calcified and moderate calcified and non-calcified lesion. In case with severe calcified lesion, MI, TVR, and MACE is significantly higher than the other condition, as you may know very well. So the calcium is really the problem in our daily clinical practice. If even the calcium is circular, but if it is very thin, we can dilate using a non-compliant balloon, and we can obtain a good lumen area after stenting. Even if the calcium is very thick, it is very focal. We can dilate using a stent as shown in this slide. However, if there are thick calcium and more than 180 degree, and if you put the stent directly, you cannot open well, and you may have under expansion, or if you dilate more, you may have the perforation at the opposite side of the calcium in this case, right? Therefore, the identification of the calcium and the decide how to treat is very important. And the additional problem is if you push the DES very aggressively at the site of the calcium, they might have the damage of the polymer, and the long-term result might be very poor based on this complication, right? So let's start the case. This is a 60 years old female. The patient have a colon cancer, colon cancer, and the surgeon sent the patient for the evaluation of effort angina. And this is the angio. The patient have the very tight stenosis at the mid LAD with calcium, right? So any kind of device with including the imaging device, we cannot pass. Therefore, we did the rotablator with 1.5 millimeter bar, and this upper slide is the result, right? After 1.5 millimeter bar, we succeed to ablate. You can see there's a very circular lumen. However, still there are thick calcium. Then we decided the bar size up to 2.0, and we can get much bigger lumen. But patient may have the colon cancer operation, so we cannot use a DAPT. Therefore, we did a drug-coated balloon with an low pressure, and then the patient did very well, and even after surgery, right? So this is another case, 70 years old male, and he had a hemodialysis. Previously he had the CABG, but this time he had an angina, and the perfusion image demonstrate inferior ischemia. This is an angio. You can identify the diffuse calcium with tight stenosis somewhere in right coronary artery. And then we did IVAS first. We can identify the severe calcium, but we cannot identify the thickness of the calcium at all in this image, right? Therefore, we select the OCT, and we can identify the very tight region and circular calcium, and from the mid to the proximal site. Then we did the low this is a still frame, the nodular calcification and the circular calcium somewhere from the mid to the proximal site. Then we decided to do the low tabulator, and then we can confirm the ablation site like this, right? Then the thickness of the calcium become less than 500 micron. We did the high pressure ballooning, and we can succeed to make a fracture of the calcium plate as shown in this slide. The calcium plate fracture is very important to obtain the stent expansion. And then we did a stent with a high pressure, right? And we could get a good stent expansion from the mid to the proximal site, as shown in this slide. And if the calcium thickness is around 500 micron, we can make a calcium fracture. And but from the distribution of the calcium thickness to make a fracture is very large, from 300 micron to 650 micron, but best cutoff is around 500 micron from our data, right? And if you succeed to make a calcium fracture, you can obtain a good stent area and the stent expansion, and the binary restenosis and target lesion revascularization is significantly low. So it is important to make a crack. This is another data from our Japanese colleague. They use the scoring balloon, and if the calcium is more than 2/3 of the lumen, and if the thickness is around 500 micron, they will succeed to make a calcium fracture, as shown in this slide. So another problem is the eccentric calcium. This is an LAD mid portion eccentric calcium. Calcium thickness is more than 1,000, right? And if you simply put a stent here, you may have the problem of the diagonal branch. The stent may pinch the diagonal branch, and the result might be poor. Therefore, we did the orbital atherectomy using a wire bias. Here, luckily, the calcium is just myocardial size, so during the pullback condition, we started a low speed orbital atherectomy, and we can confirm the effect of the orbital atherectomy. Here you can see the ablation. Then we did a high pressure, high speed pullback, and then we succeed to make an ablation, even in case with an eccentric calcium. Therefore, we did a high pressure ballooning and succeed to make a fracture, and then we put a stent, and the final result is shown in the right hand side. We could get a good result. And Dr. Fujino and Columbia group decided a scoring system using a calcium angle and thickness and length. And if the point is 4, we have to do any kind of ablation, and then we try to decide how to treat. And if the score is less than 3, you can choose the scoring balloon, cutting balloon, or non-compliant balloon to before putting a stent, and the result is not so significantly different compared with ablation, as you may know. And this is one of the algorithms. There are several algorithms to how to approach the calcium lesion. It is important to have the image, but sometimes image could not pass. There at that time we try to use a small bar size rotabulator to do the image. And if you pass the image, and if it is superficial and the score is less than 3, you can do the non-compliant balloon, scoring balloon, cutting balloon, and you can put a stent. And if the score is 4 and balloon is uncrossable, anyway, it is important to make an ablation and to pass the shock wave. If balloon crossable, shock wave might be very useful. And after you confirm the calcium fracture, you can put a stent to obtain the good lumen expansion. As I told you, if there are circular calcium, you can use the rotablator. It might be very effective to make an ablation. However, eccentric calcium, and you can use an orbital atherectomy to after confirming the wire bias. Otherwise, you may have some trouble in the normal site. It is important to confirm the wire position. I do not have enough experience of the shock wave, but shock wave may effective in case with a thick calcium, and you will succeed to make a calcium fracture using a shock wave. And finally, I just would like to focus on the nodular calcification. In this report, they missed to differentiate calcium nodule and nodular calcification. Nodular calcification is in case with stable angina. A calcified nodule is always with an ACS. And they divided in 4 types of calcium nodular calcification, and there are no significant difference even if they use a rotablator or not, right? And this is another data. They also cannot differentiate calcium nodular and nodular calcification, but anyway, compared with nodular calcification, calcified nodule may have the poor prognosis. So how to treat the nodular calcification? Calcified nodule is the big issue in the near future. At the moment, in case with a calcified nodule in ACS, I try to recommend the laser, and after laser, do not put a stent. It is important to use a drug-coated balloon. It is my speculation. We have to do the multi-center study. And this is my take-home message. Finally, in case with the heavily calcified lesion, a rotablator with small bar size would be recommended if any imaging device or treatment device could not pass through the tight lesion. OCT may allow us to demonstrate clearly the position and distribution and thickness of calcium, although IVUS might be more sensitive to detect the calcium than OCT. The lesion modification and the site and degree of ablation can be clearly observed after rotablator or orbital atherectomy by intracoronary imaging, especially by OCT. Step-by-step change in bar size and rotational speed would be recommended for ablating calcium safely using wire bias. Calcium fracture can be made by high-pressure ballooning with non-compliant scoring or cutting balloon if the thickness of it becomes less than around 500 micron. Enough stent expansion and less instant restenosis could be expected if calcium fracture can be obtained after high-pressure ballooning followed in step-by-step calcium ablation, right? So thank you very much for your kind attention.
Thank you, Dr. Akasaka, for a nice elaboration of calcium modification in coronary intervention, been supplemented by imaging. one other query about your clinical practice is how frequently and in which subset of the patient do you use scoring or cutting balloon after doing the rotablation with say 1.5 or 1.75 millimeter bulb?
Yes, yes. The calcium thickness is around 500 micron, and it is very circular. Cutting balloon is very safe, right? So we always use a cutting balloon or a scoring balloon. It's depend on a case. Cutting balloon is sometimes difficult to pass even after ablation. At that time, we use a scoring balloon. But the scoring balloon or cutting balloon, the calcium is circular. It is very yes effective and very safe. And if the calcium is a little bit eccentric, we try to use a high pressure using a non-compliant balloon. At that time, we can make some dissection and we can yes put a stent very yes effectively. Yes, that is our practice.
Dr. Reddy, welcome to the webinar. Do you have any comment about?
Yes, sir. I think the participant was a very lucid lecture. I would like to ask him one question. Can you hear me? Hello?
Yes, I can hear you and see you.
I'd like to ask, this is the good modification and get away with a drug-eluting or a DCB, because you have shown it.
Dr. Reddy, your audio is not so clear. We are not able to listen you properly.
So, coming in this question, which are all these where you do a calcium modification therapy like rotablation or another therapy and followed by a drug-coated balloon?
So, Dr. Akasaka, the question is when do you use drug-coated balloon after doing the rotablation in the calcified lesion? As you mentioned, in calcified nodule is the one subset of the patient where you prefer to go ahead for, say, drug-eluting balloon instead of putting a stent across.
That's right.
Am I correct?
Yeah. That's
Any other subset of the patient where you prefer to go ahead for, say, drug-eluting balloon instead of putting a stent? High bleeding risk patient are the one.
Yes, and also the calcified nodule in ACS, right? If you put a stent, after putting a stent, we have an dystenosis, very early stage, and you may have the experience. So at that time, the stenting is not ideal. You try to repeat and stenting and ballooning several times. So at that time, we try to at the moment I try to use the laser atherectomy and then put a drug coated balloon. That might be effective, but only a few cases at the moment, our experience. Therefore, we try to do the large number multi-center trial, I think.
Okay, thank you, Dr. Akasaka, for your nice presentation. Dr. Ajay, we are already late, running out of the time. Himanshu, are you ready to go ahead for?
You have to unmute, Himanshu.
Hello, good morning. Can you see the slides, please?
Yes, we can listen and we can see you.
Thank you so much, and thank you, Dr. Rajesh, for allowing us to be part of this wonderful meeting. I'm very sorry I was traveling with my family, so some issues with the connection, but I hope I can show some case. So I was asked to present a case which is a lesion, calcified lesion, but in a different clinical scenario like acute MI. So this patient we did in PGI about 2 weeks back. So a fresh case, 68-year-old patient who presented with acute anterior wall MI to an outside hospital with window period of 6 hours. So this is his diagnostic angiogram. We see a very long, large left main artery and a very tortuous mid-LAD, proximal LAD with the total occlusion. And there is a significant angulation from left main entering into the LED, and it's heavily calcified, as we can see the whole artery, even without contrast. So this is the cranial view where we can underestimate the angulation between the left main and the LED. And the right coronary artery was co-dominant with no collaterals to the left system. So I think the toughest part was the acute intervention, which was actually done at an outside hospital. So in the left panel, we can see the difficulty the first operator had in wiring the LED because of the angulation, but was able to wire with the XTA wire. And with some difficulty, they were able to pass a 2 millimeter and followed by a 2.5 millimeter balloon to achieve flow. At this point, they had to stop the procedure because nothing else was going. So a non-compliant balloon was not crossing beyond the ostium of the LED. And so since they had almost TIMI3 flow in the LED, they stopped the procedure at this point and did not go ahead with stenting because probably at the peripheral center, they did not have all the equipment which might be required for this case. So this case was referred to our institute the next day, and we took him up in the lab. So there were many issues. So the patient has an ejection fraction of 40% now. The surgeons they had seen the surgeons after the first procedure. The surgeons also did not feel it's a good case for grafting, as the LED was diffusely diseased and heavily calcified in the mid part as well. And rotablation also, there was some concern about doing rotablation in acute MI. However, it is more than 24 hours, but because of this angulation. So we took this patient with a 7 French guiding catheter, and we were able to cross our crossfire. And after this, I thought we'll do an IVUS, but on the left panel, you can see the IVUS does not cross. So the IVUS probe comes into the ostium of the LED and then just gets stuck. And you can see the guide getting sucked in because of the heavy calcification in the proximal LED. So it was dilated with a 2.5 millimeter balloon, and we can appreciate the angulation from coming down from the left main into the LED. So sometimes you're very comfortable doing rotablation. I would be very happy if I can do, but with this angulation, I was very concerned doing rotablation from left main to LED in acute MI patient. So the options are limited. So we used a 3 millimeter scoring balloon, which did not cross the mid LED lesion, and dilated at high atmospheres so that we could finally do an IVUS and decide what needs to be done, considering also that rotablation is not an option with this angulation in my experience. So we dilated, but again, even after this dilatation, the IVUS could not cross. But the initial examination of the IVUS revealed that there is heavy calcification in the distal left main with a calcified nodule in the distal left main, but very eccentric, 60-degree calcium, and the calcium mainly is in the mid LED. So then a 2.5 non-compliant balloon with some manipulation was crossed into the mid LED, but even at 28 atmospheres, you can see the balloon is hardly expanded proximal to the diagonal, where I think there is heavy calcification. So now there are very limited options left in the setting. So I thought maybe IVL would work. Even I did not know whether it is circumferential calcium or not, but the way it was behaving, I felt that it is probably going to be a very heavy calcium burden at that point. So with the use of a guide extension catheter, a 3 millimeter IVL balloon was crossed. And in the first inflation, you can see in the right panel, the IVL balloon is not opening after giving about 20 pulses there. But we gave about, I think, 50 pulses here, and the IVL balloon finally opened after 50 pulses at the area proximal to the diagonal. Following this same IVL balloon was used for the ostium and the proximal part of the LED, which could open with a cutting balloon also. So that was not the concern. And after that, the lesion was stented with the 2 overlapping stents, a 3 millimeter in the mid LED and a 3.5 millimeter from the distal left main into the proximal LED, considering there was no landing zone in the ostium of the LED. The stents opened well in the left main and in the proximal LED. So the left main was optimized with a 5 millimeter balloon based on the IVUS that was done previously, and then the LED was post-dilated also. And finally, we were able to pass the IVUS down after stenting the LED. And we could get an acceptable result, not a perfect result, but an acceptable result from left main to LED and good expansion. But what is most important is I would like to play the IVUS since Dr. Akasaka is here, so it will be very interesting to has his opinion. So this is in the mid LED distal to the stent. And now we've entered the stent in the distal part. And now we are approaching this. So we can see a heavily calcified area with calcium fracture from 4 to 6 o'clock because of the IVL. And as we are coming proximally, we can see multiple fractures at about 4 o'clock and 7 o'clock. Again, fractures at 4 o'clock and 7 o'clock, and well opposed stent. Again, a very large fracture at 6 o'clock. There's some side branch coming at 11 o'clock. So we could get good stent expansion, multiple fractures here also. We could see from 9 to 11 o'clock, good stent fractures. Maybe there was a nodule here with a favorable wire bias, considering the IVUS. So coming proximally, the stent is well opposed all around with stent areas in addition of 6 millimeter scare from the distal LED and almost 9 millimeter scares in the ostium LED and more than 10 millimeter scares in the distal left main. So this is the ostium of the LED. We see the circumflex coming from, I think 2 o'clock it will coming from. So this is the circumflex coming, and then this is the left main. So the stent is well opposed in the left main also. And we can see probably a calcified nodule at 5 o'clock. And the stent is well opposed in the left main. And the proximal part of the left main was healthy, which we did not stent. And there was not significant calcium there. So this was the distal stent edge with the area of 7 millimeter scares. So this is the site, MSA site was 6 millimeter scares, and we can see calcium fractures at 3 o'clock and 7 o'clock. This was the ostial LED on the left side and proximal LED on the right side. So we could get good stent expansion, and this was the distal left main. So I would just like to conclude that every calcified lesion is different, and planning based on imaging is most effective and more importantly, the safest way to do these procedures. Rotablation is backbone of treatment of severely calcified lesions. However, rotablation is not suitable for all the cases, like probably this case, and also sometimes not enough for all the cases, like large proximal vessels. And IVL is effective if there is circumferential calcium, especially in a large vessel. Thank you.
Very nice case, Dr. Himanshu, and nicely performed with good final result to the extent you could achieve a good area in the IVUS as well. Dr. Ajay, Dr. Akasaga, anything you could have done differently what Himanshu has done for this case?
Thank you very much. It's a very tough case, and congratulations, the wonderful result. Yeah, you did a very good job, I think. Yeah, this is yes, actually the circular calcium with a very the nodular calcium at the same time, right? So how to treat is a big issue. As you said, the condition is different in each case. And we have to select the best way. Yeah, we have to choose the best way, right? So, I'm not sure I can do the rotablator or not. It is very important to confirm the distribution of calcium using imaging. If the calcium is very thick, and we can use the wire bias. Anyway, try to do the ablation to modify the lesion. It might be effective. I'm not sure, but in this case, you did not choose the ablation, right? So I do not know the result if I do the rotablator. But anyway, yeah, a very tough case, and even in this case, IVL shockwave is very useful to make a fracture and get a good stent expansion. So the shockwave may change our practice in the future. We do have also the multi-center prospective trial, how to use an IVL. Yes, this is my comment, Dr. Rajesh. Yes.
So we are a little more aggressive with rotablation. To be honest, once you delivered the only thing is that we have modified our practice to use imaging, since you managed to have, first of all, Himanshu, excellent case and extremely well done under the circumstances. I think you got a perfectly acceptable result. And the only thing that we might have done differently was we probably would have delivered the OCT catheter through the guideliner and then looked at whether we would have needed to modify the lesion a little bit more. What Dr. Akasaka has focused on is absolutely there was an eccentric calcified nodule, and whatever you put, it's not going to go away. The IVUS has its limitations as far as imaging this particular segment of the coronary tree with this particular area of a problem. And useful for us sometimes is rotablation and then balloon and go back and rota again. This is a it sometimes works, and it works quite well actually, especially in patients, because you can change the wire bias, you can fracture the calcium, and when you go back and you smooth it, and you actually end up with fairly acceptable. I don't think the only thing was the bend of the LAD, but it was so proximal, so close to the left vein, that I think we could have probably managed with rotablation. And since we managed with a guideliner, I think that was a great step. So we probably could have.
Yeah. Yeah, I would agree. I would also do the same if the wire bias is favorable for a distal left main. I would like to do a rota with a 1.75 or a 1.5 bar, and then take a IVUS down or IVL later if required. But in this case, the problem was my 3 millimeter cutting balloon was actually well expanded at the ostium of the LAD. So I knew even if there is eccentric calcium, I will get an area of almost 7.5 millimeter square here. So I would not like to go into a rotablator at distal left main, considering also he had acute MI 1 day back. But so there was some thrombotic lesion also. But the main concern was the lesion proximal to the diagonal, where the balloon had absolute no expansion. So there, if I had to do rotablator, I would have to use a guide extension and use a 1.25 burr. So 1.25 burr, I was not sure that it would be enough. And 1.5 burr would have been difficult inside a 6 French guide extension catheter. So I thought maybe considering everything, considering safety, I thought IVL would be best, because I did not want to use a OPN balloon also, fearing perforation. So I tried to pass the IVUS down twice, even after using the cutting balloon for the proximal LAD, but it was not going. So once I delivered my guide extension up to the mid LAD, so I thought let's maximize my guide extension position and use the IVL balloon and not the imaging, because I'll pull back the guide extension again, So that is why.
Thank you, Himanshu. Let's try to be brief. Actually, we are running out of the time. Let me invite Dr. Rakender for his presentation on rotablation of the LAD lesion. Dr. Rakender is Professor of Medicine and Chief of Cardiology, Adesh Institute of Medical Science and Research, Batinda. Rakesh, please. Rakender. Dr. Rakender, please.
Hello, sir. Hi.
Yes.
Thanks, sir, for inviting me for this wonderful opportunity to present my case. Sorry, actually, I am also traveling, so right now I'm in my car and presenting the case. So basically, this is an elderly 54-year-old male who's a hypertensive, had chronic stable angina, is an extensive smoker with extensive COAD. We're having extensive rhonchi when he came for the admission. TMT was positive previously in the LAD territory with significant around 5 mm ST depression in the LAD territory. So this was the initial angiogram, which showed around 40 to 50% lesions in the proximal RCA, and distal RCA had around 80% lesion in the PDA branch. But also what is seen is the LAD is filling retrogradely through the right circulation, both the LAD and the diagonal, and there appears to be significant calcium in the proximal LAD. So then the left check shot showed a complete occlusion of the LAD after the septal branch, and a lot of calcium again from proximal to almost mid LAD lesion. And again, also the circumflex ostium was involved, as well as the ostium of the first OM. Circumflex is non-dominant, and the OM branch, second OM, is also CTO with some retrograde, some filling through the collateral channels. So we initially tried Gaia 1 with the caravel support, but unfortunately there was some buckling and the wire was not crossing. Then we used the help of Gaia 3rd with caravel. Fortunately for us, it just went like a knife in the butter in the LAD. So as you can see, the Gaia 3rd went actually into the diagonal. We thought it was the LAD, but it went into the diagonal. So these were the other check shots, after which we realized we inflated the proximal with the 1.5 and then 2 mm Tazuna in 2 into 12 mm Tazuna. And then here we realized actually it has gone into the diagonal. Then we repositioned the wire, but unfortunately the stent was not crossing. We dilated with 2 and 2.5. Then we thought, let's go in for a rotablation. We took a rotablation with 1.5 mm bar at 19,000 RPM, but the guide was not giving any support. I know after a balloon dilatation, rotablation is a relative contraindication, but since I thought there is no significant dissection in the LED, we went ahead with the rotablation. Then we gave a good guide support and did the rotablation, and the vessel was opened to set better extent. But then again, the stent was not going to the distal. So if you can see here, we have expanding a Ruri 1 into 5 mm balloon at 10 to 12 atmospheric pressure, after which we had a reasonable flow. The proximal LED was again redilated, but still the stent refused to go. So then we used another 1.25 bar of the rotablation, and we shaved off the whole of the LED almost up to the distal part of the LED. We got a reasonable result with a lot of dissections. Then again, the adequate pre-dilatation was done with 2 and then 2.5 mm balloons. Then a science expedition 2.5 into 38 mm stent was deployed from the mid proximal to the mid LED at 12 atmospheric pressure, and another stent 3 into 18 millimeter against science expedition was deployed at 12 atmospheric pressure from distal left main to the LED. The post dilation was done with 2.75 and 3 in the mid to distal LED, and 3 and 3.5 millimeter in the left main, distal left main. So this was the final check shoot, which showed a good apposition of the stent and TIMI3 flow till the distal LED. So take home message is densely calcified lesions are treatable. Along with the presence of scoring balloon, the availability of rotablator makes the life easier for many of us interventionists. You need to be well versed with rotablation, and rather than waiting for rotablation, we may be a bit more aggressive and do rotablation early in the course to make our life easier, to help the stenting these lesions better. Actually, I missed out on one point. After the angio, the patient went home because we had advised CABG in this case. But when they got in touch with the cardiac surgeon, the surgeon and the anesthetist were not very keen on taking him for surgery because of the COAD. And then they came back for plastic. Thank you. That's my case, sir.
Thank you, Dr. Rakendra. Very nice presentation and beautiful result at the end after using rota and also the scoring balloons. Let me complete the session over here as we are running out of the time. I'm thankful to all the panelists and also the speaker for this wonderful session of the coronary calcification and the intervention. Let's move forward for the next session. That's about the management of the bifurcation. And let me invite the expert panel, Dr. Arun Chopra. He is currently the Director of Cardiology, Fortis Escort Hospital, Amritsar. He has a vast experience of around 25 years in performing coronary and non-coronary diagnostic and therapeutic procedures. Dr. Chopra is also an expert cardiac electrophysiologist. He is the faculty of various cardiology conferences in India and also internationally. I have the privilege to invite Dr. H.K. Bali, my teacher, who is a chairman at the cardiac sciences at Paras Hospital, Panchkula. Dr. Bali, as you all know, is a senior cardiologist with vast experience in complex coronary and also peripheral intervention. He has the expertise in heart failure and structural heart disease and imaging as well. He is an elite faculty in most of the national and international conferences. Let me also invite Dr. Animesh Agrawal, a senior consultant and head Department of Cardiology at Jindal Institute of Medical Science, Hisar, Haryana. Dr. Animesh is skilled in performing coronary, non-coronary peripheral intervention. So, to proceed further, let me invite Dr. Bali for his presentation on coronary and venous intervention when there is no option for revascularization. Dr. Bali, please.
Good afternoon, everybody. Can I share my screen, please? I hope my slides are visible.
It is visible.
Thank you, Rajesh, for very kind words of introduction, and my congratulations to you for such a wonderful conference.
Thank you, sir.
Great take for this area. So we have been dealing with patients of coronary artery disease for a long period of time, and today every interventionist practice would involve at least 5 to 7% patients who are post-bypass and who come back for intervention. And many of these cases have diseased native vessels, and we prefer to do native vessel angioplasty in case that is possible, because saphenous vein graft angioplasty has a limitation because the significant atheroma with distal embolization taking place, so MACE is higher and the restenosis rate is also higher. So whenever there is an option, we would like to do a native vessel angioplasty. But there are occasions when native vessel angioplasty stenting, despite improving technology and expertise, is not feasible or not possible. So we have to go ahead and do a venous intervention in these patients. So I'm going to take present few cases to show that in those patients where there was no other option, surgery had been denied, refused, and native vessel angioplasty was not possible, and lesions in venous graft or Lima graft were very, very challenging, and it was very satisfying to do intervention in these patients. And these are the few cases I would be presenting, and they were challenging as far as real patients. So first patient is an 89-year-old male patient who presented with us cardiogenic shock. I had followed this patient for the last about 20 years. I sent him for bypass surgery, seen him post-bypass, and I knew that he had only one venous graft which was functional, which was to a PDA, and rest of the venous graft had got occluded over a period of time. His ejection fraction over a period of time had reduced to 25%, and he presented to us with cardiogenic shock. With this previous knowledge, I knew that the lesion is going to be in the venous graft to PDA. And at the time when he presented with cardiogenic shock, he was on high inotropes. His ejection fraction had reduced to 15%. And this is what we found on his this is the only functional venous graft. And you see a lot of thrombus in it and almost near total occlusion. So we went ahead and did an aspiration in this particular patient to get some flow into the vessel. And after that, we put in a distal protection device. This is a spider device. And you see a tight lesion at the venous graft and distally. And we did a balloon angioplasty of that. And after putting in 2 stents, this is the, and optimizing the stent, this is what we got finally. And the result showed very good flow into the right coronary artery, and patient came out of cardiogenic shock and was discharged in a very stable condition. So another patient, 85-year-old male, presented with progressive angina and LV dysfunction. He had diffuse disease, chronically occluded right coronary artery SVG graft. We had to use a combined antegrade and retrograde injection in this particular patient. You see a diffusely degenerated venous graft, and distally it is occluded, and obviously the distal direction of the vessel was not obvious antegrade. So we used a native coronary angiography to find out the distal vessel. And this is the native coronary angiogram, which shows the distal right coronary. And using that as a roadmap, we were able to cross this lesion and into the PDA, and then subsequently by doing angioplasty with the high pressure dilatation and putting in 3 stents. Post optimizing the stents, we were able to get a very good flow into the distal vessel. So CTO, diffusely diseased subcutaneous venous graft with no other option. 82-year-old male patient had a bypass surgery in 1988. He had a redo bypass surgery in 1999, and he had no recurrence of symptoms till 2014. And he presented to us with acute coronary syndrome. And we knew the angiographic finding of this patient, and when we did a angio in this particular patient at this time, we knew the venous graft was from PDA, but there was a very large PL, and that was the reason for his acute coronary syndrome at this time. And we, with previous knowledge of his angiography, we knew that PLV was a very large vessel. His top was very significantly elevated, so we went ahead and did an angioplasty of this. Getting into this almost a Z-shaped vessel was extremely tough, so we used a microcatheter to get a guide wire there, then change it to an Iron Man wire, and subsequently when we were still it was very difficult to manage a balloon across this Z bend, and then we took a small balloon, dilated the lesion, and then getting a stent was almost impossible. So I had to take the guide catheter right at the junction of the graft to the PDA, and if I were doing it today, I would probably be using a guide liner, but at that time guide liner was not available, so I had to manipulate the guide catheter right at the junction, and then use 2 small stents. Anything more than 12 millimeter stent was not possible to manipulate into that distal vessel. After using 2 stents, small 2 stents, we were able to get a very good result into this large PLV, giving us a very satisfactory result. Now, 86-year-old male patient, he had bypass surgery and came to us with angina, and he had a Lima CTO, a Lima to LAD CTO, and this is Lima, and you can see distally beyond the anastomosis, the vessel is chronically occluded. So we decided to do this Lima to LAD angioplasty. And in those days, I was very fond of Shinobi guide wire. So we used Shinobi guide wire to get to cross this lesion. And then 1.25 millimeter balloon, 1.5 millimeter, 2 millimeter balloon. And then we were able to get a good flow into this vessel at using the balloon at high pressure. And subsequently delivered 2 stents to get a good result into this Lima to LAD angioplasty vessel. And after optimization of the stent, you see the flow into the Lima to LAD. This is CTO of Lima to LAD. 87-year-old male presented with acute coronary syndrome and impending cardiac shock. He had multiple culprit lesions, and this is the venous graft to LAD, which has 2 lesions. In the proximal part of this, there is the ulcerated plaque, and distal anastomotic side, there is another lesion. So 2 lesions in the venous graft to LAD, and this is the anomalous circumflex to one of the OM, which has a critical stenosis in mid part, and another obtuse marginal S3G, which has a critical stenosis. So 4 lesions, 2 in LAD, proximal and distal anastomotic side. One is an anomalous circumflex vessel, and one in the another venous graft to OM. So we went ahead and did an angioplasty stenting of all these 3 lesions. This is the angioplasty stenting of the SVG to LAD with 2 stents, one in the distal part, one in the proximal part. After optimization, good result. We could not use a protection device in this patient because of the site of lesion. And this is the venous graft to the obtuse marginal, which is being managed with angioplasty stenting. After stenting, and then we went ahead and did an angioplasty stenting of the anomalous circumflex, and this is the final result. So I think the time is running out, so I will present one more case. This is a retrograde SVG plasty, a totally occluded first CTO. Now this patient had a bypass surgery and a jump graft, venous graft to LAD and OM, another graft to PDA, and he came to us with the occlusion of this graft, and we did a left main to LAD angioplasty. And after that, subsequently, he came with occlusion in the mid part of this vessel. The stent got occluded, and then he came back with the angina. Now this venous graft is filling retrogradely. And this we decided to do this retrograde angioplasty stenting of this venous graft through this native disease circumflex artery. And this is, we were able to retrogradely cross it. And I think I need to write down because, Rajesh, can I have a minute more? Okay, so this is after we had to do angioplasty of the circumflex, and you can see that the guideliner was used because this is through the lima to the left main to LED stent. The guideliner, and then we were able to do angioplasty stenting of the distal vessel of the jump graft. And he presented with retrosternal chest pain again, and this is where the angioplasty stenting of the venous graft we had done, and then ISR of the venous graft, and there is the limb into the obtuse marginal also disease. So we ended up doing a bifurcation stenting of this venous graft akin to a left main angioplasty stenting. This is balloon angioplasty being done, and subsequently we did a mini crush technique to do, this is the stent being deployed in the obtuse marginal limb of the venous graft, and then stent into the LED, and kissing balloon angioplasty, and then finally a pot. And after that, we had a very good flow in the both the venous graft. So I think I will stop here because of paucity of time. There's another patient who had 2 lesions in the venous graft, so I think I will just rush through that. So what I would say is that in patients who are post-bypass, doing the native coronary angioplasty is a preferred treatment option. We today can do long segment CTOs as well, and most of these patients native vessel angioplasty is possible. But there are patients in whom there is no option, and native vessel angioplasty is not successful or is not possible. In those patients, doing complex venous intervention remains an option, and if the procedure is done well, it does give a long-term very good result. So these were some of the challenging cases which were very satisfying in the last few years. Thank you.
Thank you, Dr. Bali, for nicely performing and showing these technically challenging bypass graft cases. They are very educative. Just for those who are the young cardiologists and fellows attending the meeting, your comment about, say, guide catheter and guide length preference for these cases, because we do come across the problem of shortening of, say, balloon catheter or stent catheter when you are reaching distally for this bypass graft, like you had no problem in going for the PDA stenting. So any particular comment or suggestion would you like to give for those young cardiologists?
I think for venous graft, either we use an AR or AL1, and I have found that to be a very good catheter and to get a good score. And sometimes, if you're not getting a good score, guideliner use can be very good to get a use, and especially the angle is very acute. In distal vessel, sometimes you need to cut the catheter, and so get a longer length of the catheter. And extension, guideline extension can be telescoped as well to reach the distal segment of the vessel. So there are some technical manipulations which you have to do on table to manage some of these patients. But I think in the hand of experts which we have now, it's not that challenging. More challenging is to take care of those thromatous lesions, because distal embolization is extremely common, and we have to use some sort of a protection device. I have found use of vasodilators, and my personal choice is sodium nitroprusside, very effective in such patients. And when we do balloon dilatation, we try to do a very slow dilatation of the balloon so that the proximal and distal end of the balloon inflate first and then the central part. So that is another technique of, just preventing a distal embolization. Try to undersize the stent and not post-dilate it very aggressively. So these are some of the things which we have to use in patients who have venous graft disease.
Good afternoon. Yes, good afternoon, Dr. Bali. Pleasure to see some wonderful cases. Meeting you after, I think, a few months. Anyways, great cases. And I would just, they were all worthy of discussion. But I would especially like to ask you the case where you did retrograde crossing of the jump graft. So what did you do? You went through the native artery and then punctured into the aorta? What did you do?
Yeah, you know, this venous graft was a jump graft which had occluded ostially in the proximal segment, and it was fitting retrograde from diffusely diseased, heavily calcified OM branch.
Yes, that I saw.
Into that and then integrate into filling in that. So I had to go through the stent from left main to LAD into that obtuse marginal branch, manipulate a guide liner because getting a balloon was tough, and then cross retrogradely into the aorta. I tried to snare that wire. I did not succeed, but I had to take a small balloon, 1.5 millimeter, to dilate the ostium of that venous graft. And once I had dilated it, then I hooked to the vessel antegrade and passed a wire into LAD, LAD limb of the venous graft. So I had two wires, one retrograde, one antegrade, and then subsequently I had both the antegrade wire. And then first time I did one stent proximally into LAD, and the venous graft to obtuse marginal was flowing very nicely. Subsequently, he came back with instant stenosis when I did a bifurcation stenting of that venous graft, both the legs.
That was the most educative case. The other thing that I would like you to guide is regarding that case where you didn't have the guide liner and you had to get in stents into the very tortuous PLV, and you took your guide catheter almost to the ostium of the PD and PL. So while we used to do this earlier, I think nowadays nobody has to do it because of guide liners, but there may be a situation when people don't have access to one. So I would like you to tell the younger guys how you manipulated your catheter till there safely.
I think what we need to do is I used a balloon in ahead of the guide catheter and dilated it to 2 atmosphere and manipulated the guide catheter on top of it, and went distally with the balloon and kept on creeping that guide catheter deep down. So I had to be very careful because it was a friable vessel I was dealing with, and there was no pressure applied, and it was a very slow maneuver, and we kept a watch on the pressure of the patient, the heart rate of the patient, and it was a very smoothly done, very slow procedure to get the guide catheter right there. There was no other method I could have got down there. I used the buddy wire, I used all sorts of techniques, and even getting a balloon I could get finally, but getting the catheter was almost impossible. I called it a Z angioplasty at that time. We have done 3 such cases subsequently, similar cases. And in the other cases, I used a guide liner now, which is much more easier to use. So now it has become easier to do.
Okay, sir, I think we'll move on to the next.
I have just one query, sir, if you can permit me.
Animes, we are running short of time. Let's go ahead for the next presentation, please. So let me invite Dr. Syed Maqbool. He's going to talk about non-left main complex bifurcation stenting. Dr. Maqbool is presently working as associate professor with the Khyber Hospital, Srinagar. His keen interest is about the complex coronary and non-coronary intervention, structural heart disease, imaging, and preventive cardiology. Dr. Maqbool, please.
Good afternoon, sir. It's a great pleasure to be present in this meeting. I'll be presenting complex non-left main bifurcations. Can you see my screen? Are you seeing my screen?
We are not able to see your screen, please. Now it's visible.
It's visible, sir?
Yes. You can go for the slideshow.
Yeah, good afternoon, sir. It's a great pleasure to be present in this meeting with all the grades of interventional cardiology. I'll be discussing complex non-left main bifurcations. Coronary bifurcation disease accounts for about 15% of all lesions seen on angiography, which most are simple, but 30% of them are complex.
Dr. Maqbool, can you make it enable editing and then go for the slideshow so we can have a proper projection of your slide? You do the enable editing on the
right, sir.
upper bar, yes, enable editing, that's right. And now you have stopped sharing the slide, I think.
Yeah.
Can you again try?
I'll just do it, sir. Can you see my slides now, sir?
No, it's not visible.
Can you see it now, sir?
No, it's not.
Is it visible now, sir? Okay, just
Yeah, that's what.
it's visible now?
It's visible. It's visible.
Yeah, I'm trying to make it. Is it visible now, sir?
No.
Is it visible now?
Dr. Makbul, can we go for the next? Yeah, you can present with this only. In case you have no difficulty in having the slideshow.
Can somebody else present for the time being?
Yeah, that's what. So let me,
right.
okay, fine. So let me ask Dr. Karun Bahal to present his presentation on current EBC guideline for bifurcation PCI. Dr. Bahal is a senior consultant cardiologist at Fortis Hospital, Mohali. He has done his DM from KGMC, Lucknow. His special interest is about the complex coronary intervention and the heart failure procedure. He is in credit of various publications, both in national and international journals. Dr. Bahal, please.
Good afternoon, everyone. I hope I'm visible and my slides are clearly visible to everybody. And all of you can probably hear me, I think, appropriately. And let me first thanks Dr. Rajesh for giving me this opportunity to present on bifurcation PCI. So I will be presenting the current European Bifurcation Club consensus statement, that is 2020. So I would try to finish my talk within the stipulated time. So European Bifurcation Club, it was initiated in 2004. It's basically a very noble club which is organizing events every yearly basis, on annual basis, so as to form a consensus about the various techniques for the bifurcation, so as to improve the outcomes for the patients with the complex bifurcation lesions, maybe the left main, unprotected left main interventions as well. And the data which they have summarized, basically they on annual basis they pull up the data, so they have the best of the people from the field of interventional cardiology to focus on the advances what have been done, and what really the data has come out from all these consensus statements is that the final outcome of the bifurcation coronary lesions is strongly influenced by the factors which are denoted by the stent characteristics, then the techniques which we are using for bifurcation, and the procedural steps. So just a reminder for all of us what a bifurcation lesion is, as defined by the European Bifurcation Club, is a coronary artery narrowing which is occurring adjacent to or involving the origin of a significant side branch. And a significant side branch, EBC says, is a branch that operator does not want to lose in the global context of a particular patient. So this is how they define a bifurcation lesion. And EBC, they endorse Medina classification for the bifurcation anatomies, and for the stent techniques in the bifurcation. In 2008, the European Bifurcation Club, they coined a term called MADS, which really tells us the stent which we are implanting in a bifurcation for the first time. So that on the basis of that, they say this technique that they should be characterized as what they call as a MADS, which it stands for a main vessel, then A stands for an across the side branch, D stands for a double lumen, and S stands for the side branch. And so this was coined in 2008, and subsequently in last 10-12 odd years, what they have seen is a few techniques have been refined further, and few techniques have really have been abundant. So in 2020 consensus statement, they have coined a term, they have upgraded it to MADS 2 classification for the nomenclature. So I will be discussing subsequently. And for the balloon dilatation, they have given a three types of the balloon dilatation techniques, which can be denoted by single digits. That's a P for what we typically call as a POT, or that's just a proximal vessel optimization technique, that is POT. Then an S is for the side balloon dilatation, and then K, that is for the kissing balloon dilatation for the main vessel and for the side branch. So these three terms they denote the balloon dilatation at the different points, and this is what MADS 2 classification of bifurcation stenting is as per by the European Bifurcation Club. So M, as I have told you, is for the main vessel proximally. We are putting a stent in the main vessel, so we are dilating that, and then subsequently we can have a skirting, and then we can be putting up maybe a one or two additional stents into the distal main vessel or into the side branch. And then for A, that is across the side branch, here we place a stent from the main vessel into from the proximal to the distal part across the side branch. Then we do a POT and then a kissing balloon dilatation. And so we may be stopping here, and if we need an additional drug in the an additional stent in the side branch, we may be doing a T, maybe doing a tap, or a culate. That is a classical culate. It can be done. It can be converted to that. Then D is for the double lumen, that is for the V stenting or the SKS stenting. I think not very preferred these days. We are not except in the selected cases. Then as for the side branch first, where the side branch we feel is very important, we may be doing the side branch first. So we may be putting a stent in the side branch, then doing a kissing balloon, and then maybe converting it into an intentional T stenting, or it may be a dedicated DK crush, double kissing crush. And for in the MADS 2, what they have done is, in addition to MADS, they have an inverted A, where we have a stent which is going from the main vessel into the side branch. So then we are doing the POT, then the kissing, and then we may be placing a stent into the main distal vessel. So it will be an inverted T. So if we are just pulling the stent a little bit, we may be doing an inverted tap and then an inverted culate. One of the most commonly used, I think, that is inverted culate. And then DM is for the distal main vessel first, and then subsequently we can again maybe putting a stent into the main vessel or into the main vessel as well. So this is MADS 2 classification is for the stenting. The uniformity of reporting of the bifurcation stenting, it becomes very easy. And what European Bifurcation Club very clearly tells us that we can have a provisional one stent technology, or that is which is the gold standard. But if it's a complex bifurcation with a significant involvement of the side branch, then we can go in for a two stent techniques as well. And complexity is defined by the anatomy, then disease distribution, then ease of access of the branches. For a single stent technology, that is the technique we are using either for the non-complex bifurcation lesions or where we feel that the side branch occlusion risk is very less, or even if it occludes, then we will be able to for an easy bailout. Whereas for the two stent, we have a dedicated, we can use a T tap, we can have a culate or the DK crush, where we feel the side branch access is very saving that is very important, and it may be difficult to retrieve at a later point of time. And so what European Bifurcation Club tells us is that if there is not a major concern for the side branch occlusion or the re-access, one probably would safely go in with a T tap or culate stenting. But if we feel that the side branch may be very difficult to access at a later point of time, the best options would be an inverted T, inverted tap, maybe an inverted culate or the DK crush from the very beginning. So just a brief about, I think, one stent techniques, as we all know, putting the stent across the side branch. Pot is very, very important. Then crossing into the side branch, then kissing, and final pot is the thing which is very important. And they say the placement of the balloon for the pot is very important. It has to be just proximal to the carina. So this is something which is very, very important. If you are too proximally or too distally, you may be injuring the carina. So that's not going to give you the good result. And this is how a provisional stenting would look for the good access for the side branch on a micro CT or the distal main vessel in the inverted positional stenting. Then an inverted provisional techniques, we are going from the main vessel into the side branch, then pot, then crossing the main branch, then kissing, and in the final pot is the answer. So this is T and tap. They are saying they are still one of the most widely used technologies treatment for the bifurcation because they are very, very easy. And what is very important is with the tap, we need to have a very limited pullback of the stent so that the neurocarina is not very far off. So they want a very limited pullback into the main stent. So we'll be placing the stent, then doing a kissing and a repeat pot for the tap, and this is how a tap would look on a micro CT, and this is how a T would look on a micro CT. Culate is again something which is again finding use quite a favor because of the drug-eluting stents. But the important thing is the stent, whichever we are using for culate, should be quite expandable so that you can probably dilate it to quite a significant diameter of the proximal vessel, that it should be able to be expandable to that limit. So that is very important. And what again they are saying is with culate, you again need a very limited pullback so that it may be a DK mini culate. This is something which they are encouraging. So culate again, side branch, then crossing, then main branch, then kissing, and then the final pot. So they have given a lot of weightage on the pot. And DK crush again, they say is an excellent technique, but it's complex. We have to recross the crush stent twice. So twice kissing has to be done. So one has to be very meticulous. So should be done by the very, very experienced operator. So and DK crush is again, this is how it would look like. But only problem would be there would be 3 layers of the stent in the proximal main vessel on the lateral side. So just coming to the conclusion, the European bifurcation, it lays a lot of weightage onto the simulation models, being in vivo, in vitro, or on the computational simulations, so that one can actually plan it for a patient, how the stent is going to behave in the vessel. There is lots and lots of weightage on the intracoronary imaging, especially they say an OCT combined with an angiographic co-registration. It would give us a 3D imaging, especially if you are doing a bifurcation where the wire is crossing through the side branch struts is something which is very important. So OCT or an imaging, maybe an IVUS as well for the ostial left main or for the very large vessels is important. Drug coating balloon, especially for the restenosis. We already have a restenosis at the bifurcation site with 2 stents. So this is something which is quite promising. For unprotected left main,
Dr. Bad, will you please conclude? We are running short of time.
5 seconds, sir, 5 seconds. So for left main, they say have a heart care team approach to really decide which patient is going for a CABG or for PCIs, and antiplatelet therapy again may be required for more than 12 months because of these are the complex lesions with a lot of thrombosis, chances of thrombosis as well. So the take-home message from the European Bifurcation Club consensus statement is that the bifurcation stenting techniques, then the intracoronary imaging, then the bifurcation simulation models, then drug-eluting balloon technology, and the tailored antiplatelet therapies, These are the cornerstones for improving the clinical outcomes of our bifurcation patients. Thank you very much. Thank you.
Thank you, Dr. Bail, for brief presentation of bifurcation stenting and various technique. A comment from your side regarding the side branch assessment after provisional single stent strategy, how to assess with the imaging and with the FFR functional assessment. What's the recommendation to assess for?
So they say honestly the assessment of the side branch is still it is debatable how we should do, but definitely I would say probably imaging is the best, especially with an imaging like an OCT these days, which we are using so often. We can have a really look at the stent studs which are coming onto the side branch ostium. So I would as if I have to pick up a single investigation tool, I would say it's an OCT. So that we can really have a look. And what they are saying is a OCT with the real time angiographic integration, so that we can have a clear look where our side branch is crossing, so through the main vessel struts, so as to have the good dilatation, and we can define even the new carina in a very good fashion, so that even the port, which is probably the very important in a patient bifurcation, your port has to be just proximal to the carina. So I would say OCT is the best, I think as of now, to the best of my expertise.
Very nice, Dr. Bahal. So let me go for the next presentation, constraint of time. Let me invite Dr. Kunal Mahajan, who is Assistant Professor Department of Cardiology at IGMC Simla. His special interest is about imaging guided PCI of the complex coronary lesion. So Kunal, please go ahead with your presentation of imaging guided bifurcation PCI. Try to stick to your time of say 8 minutes or so we can have an appropriate discussion as well.
Thank you, sir. Thank you. I will be presenting a case on imaging guided bifurcation PCI. This case presented on this month only on 5th of February. He was a diabetic, hypertensive smoker, 56 years old male with exertional angina for last 2 months, and is very strongly positive TMT at 6 minutes. Echo was normal. So he was taken up for angiogram, and you can see that there was a very tight LED diagonal bifurcation 111, but the disease at the ostium of diagonal was very focal. So in the next view, you can again appreciate the Medina 111 LED diagonal bifurcation. It was very tight disease of LED. And in the caudal view, you can appreciate that there is a very tight disease in the LCX as well, almost 90-95% stenosis, followed by tandem around 50% lesion distally, which we were not going to target. And ostial LED also appears significantly diseased. And again, in this another caudal view, ostial disease of LED looks significant, and the distal L6 lesion is also appreciable. So RCA was dominant and normal. It was giving collaterals to LED. Pain collaterals were there. So this was the image diagram, plaque distribution. You can see that we were dealing with a double vessel disease with a LED diagonal, very tight bifurcation, with diagonal disease limited only to the ostium. And this is a very tight disease in the LCX, almost 95% stenosis, and ostial LED also appears disease, almost 60%. And there was some hint of plaque at the distal end of left main. We calculated the syntax score 23. Syntax 2 was calculated. Things were discussed with the family. All benefits and harms were explained. And at that moment, they refused, but and were discharged. For CABG was not available with us. We gave an option of PCI, and since there was a possibility of distal left main involvement, we believed that imaging was mandatory here to see this, whether we should go for a single stent, LMCA to LED, or 2 stents. And bifurcation across LED diagonal was also debatable because the disease was very focal, limited to the ostium. And as per guidelines, if disease is less than 10 mm, then we can go with the provisional approach and switch to 2-stent strategy at any moment. He came for PCI with worsening angina on 24th of February on this Wednesday only. And this is what we planned, that we will take a 3.57F EBU, right radial approach will be used. We will wire both LED and diagonal. Then we will image. Imaging was mandatory to see the extent of disease in the LED and whether there was distal left main involvement as well. So we'll take a decision after that. And we decided that we will pre-dilate D1 and keep it for provisional strategy only, since the disease was limited to the ostium. And first we will tackle LCX after dealing with LED diagonal, and before fixing the LED ostium, we will tackle circ, because otherwise it will get chilled. So this was the EBU picture, guiding picture. You can see again that flow had certainly slowed down as compared to the previous angiography. So that is a worsening of symptoms were there. When we passed wire across D1, immediately flow in the LED stopped. So we had to use wire was not going easily into the LED. This we had preempted, but never knew this will happen. And with the balloon support, we were able to negotiate wire across LED, and flow was balloon dilatation of both LED and diagonal were done, and we could restore flow across LED diagonal. But flow in diagonal was still slow, which I ignored at that time, frankly speaking, and that will be the we will face the consequences later on. And this was the caudal view. You can clearly appreciate that very tight ostial disease of LED was there. And at this moment, we did both IVS and OCT to see certain things, and mid-LED disease was very, very tight. You can appreciate that. This was the tightmost point where we had already ballooned, and there was diffuse involvement of LED up to the ostial LED. So we had to stent whole length of LED. It's clear, and this was the picture at the ostium, which was very tight. Disease was there, and distal left main was also involved, as in most of the cases with ostial involvement of LED. There was 62% plaque burden at the distal left main, so we could not nail the ostium. We had to cover from left main to LED, and so we were dealing with two bifurcations now. One was LED diagonal, and another one was LED LCX, and with after doing the distal L6 plasty. So this was the diagonal disease. You can see this was very limited, only 3 mm in the longitudinal view. 3 mm disease was there, and plaque burden at the ostium was 61%. We thought we can just leave it to the provisional approach. OCT images were also taken to be very, very sure regarding the ostial LED and distal left main disease, and same findings were observed. There was tight disease at the distal left main, not so tight, but there was significant disease at the distal left main and ostial LED. So plan was to stent LCX first, then LMCA to LED crossover stenting across L6 and diagonal 1, then optimize both side branches with KBD and POT. So this is how we went ahead with our business. First fixed the LCX lesion, dilated with 2.510 balloon, then deployed a stent across that, and used 3 to 20 mm stent, post dilated with 3.5 to 10 NC balloon, and this was the result. But when we saw, when we saw on IVS, there was gross malposition of the proximal part of L6 stent. So we again post dilated, and on the right hand side, you can appreciate that the stent was well opposed now. So we had optimized the result of distal L6 stent. Now was the time for LMCA to LED lesion. We took a 3 into 44 sirolimus eluting stent, and the best part was that it could be dilated up to 4.5, and LMCA with imaging, we knew it was luminal area was 4.4, so we had to dilate it up to 4.4. So we thought a single stent would solve the purpose. It will give us appropriate dimensions in the left main. So we took a single stent, did not cover the ostium because ostium of left main was not diseased, and thus we deployed a stent. This was the stent deployment. However, I was continuing to ignore the LED decrease in diagonal flow, and that is what happened. Diagonal got flush occluded, and then I did POT across the LED diagonal origin, just keeping the margin in front of the carina so that it could scaffold the struts towards diagonal, and probably flow might improve, but it did not. And so I now expected that I had to pass multiple wires to recross the diagonal. So I had to post-dilate the proximal portion of the stent, because otherwise I will go abluminally, not through the lumen. So first I post-dilated the LED portion with 3.5 into 10 mm NC balloon, and then did POT across LED left main with a 4.5 into 8 to avoid abluminal crossing of new wires, which I would now take. Then I took run-through wire, whisper wire, all new wires, filter XT, but nothing could go in. I reverse loop, everything, all possible techniques were used, but nothing would go in. So I had only two options left. One, to go abluminally with a smaller balloon, dilate, but that was catastrophic because I had stented from left main, and it could disturb the geometry of whole of the left main LED stent. So I did not want that to happen. So what I did, I took a microcatheter, and with that Gaia 2 wire was taken, and with the help of microcatheter, I could somehow negotiate this Gaia wire into the occluded diagonal branch. And after doing this, I removed the jailed wire, which was previously placed there. And now struts were dilated with 1.5 into 10 mm balloon. And after that, as expected, what happened, there was a large dissection noted in the diagonal one. So I had to, this was a significant branch, I had to cover it. I was ignoring it previously, but now I had to cover it. There was a large dissection. And now I could not continue to give multiple injections. And with Gaia, I had a risk of wire tip perforations also. So what I did, with a microcatheter, I removed Gaia and placed run-through wire. So I was safe with the tip perforation, but now I had to assess what was the length of dissection. And secondly, I could not keep on giving more injections. I thought imaging is the best here. I took a IVS run and found that there was a large intramural hematoma and dissection across the proximal portion, starting from the ostium of diagonal across to the proximal portion dissection, and length was measured.
So,
Kunal, can you show the final result, please? We are running very short of time.
Only 1 minute, sir. So I covered with a another stent 2.5 into 28 using Kilot technique, and this was pot was done. So distal PD was done, then kissing balloon dilatation, repot, and this was the final optimization of LED diagonal. Now another question was that what to do with L6 struts across LMCA to LED, as sir has previously discussed. There were struts across L6 on the OCT run, so I did a kissing balloon dilatation with 3.5 into 12 LED and 3 into 12 L6 dilated at low pressures. And post this OCT run showed there was no dissection across L6 ostium, and L6 was free of any struts. So final report was done, and these were the final caudal views. You can see there was good coverage across both the bifurcations. And this was the pictorial view, and this was the allocranial view, which showed a good neocarina formation compared to the previous one. And this is the image diagram, which showed very well optimized, and L6 ostium was free of disease struts. These were the imaging I optimized, and this was a very good neocarina formation at LED diagonal. And again, the same view of OCT pullback. Again, this is the ostial LED good MSA of 11, left main good MSA of 15.5. And these are the OCT images discussing the same thing. So we had got a very good result. Probably the disease in side branch was very significant. That led to side branch occlusion. And also on OCT, we can predict that, which I did not know at that moment. When carina tip angle is less than 50 and branch point to carina tip length is less than 1.7 mm, it has high chances of closure. And in our case, both criteria were present. So the take home from this case were provisional is recommended for majority of bifurcation lesions, including LMCA. It always preserves the option. You can always switch to a two-stent strategy at any moment. In complex bifurcation where side branch disease is less than 10 mm, provisional is as good as a two-stent strategy. But predictors of side branch closure should always be assessed in detail. And we should use imaging and physiology liberally to optimize our results. Thank you so much.
Very elegantly performed this case of a two bifurcation lesion. Dr. Bali, any comment, please? Dr. Bali is nothing. So, because of the time constraint, let me invite Dr. Florian for his presentation on OCT, on precision PCI with angio-core register OCT in bifurcation lesion. Dr. Florian Kukli is internationally acclaimed intervention cardiologist in Lausanne, Switzerland. He is the director of the Cardiac Center at Lausanne. Dr. Kukli is known for his pioneer work in the complex intervention management, coronary imaging, which specifically include OCT, and has various research papers published under his name. I had a privilege to visit his center when he had performed a day prior around 3 TAVI cases, so he is expert in TAVI and structural heart disease as well. Dr. Kukli, please.
Thank you very much, Rajesh, for your kind invitation to be here. And I would like to share with you my experience with OCT, especially in bifurcations, but not only, I have a nice surprise for you and I hope you will enjoy it.
Please.
So before we start, I think it's very important to remind ourselves why PCI fails, because when we do PCI, we really like to have good long-term results, and PCI fails for some reasons. One reason is, of course, diabetes, which I am aware of. I've been many times to India, and I know you have a big problem with diabetes, but a lot of the problems are also mechanical. So CTO, ISR, long lesions, small diameter. And I think we have to really remind ourselves that by creating lumen, we really make sure we have good long-term results. And OCT will help us to create more lumen and with this to have good long-term results. And especially in bifurcation lesions, the lumen you create at the carina in the ostium of the main branch and the ostium of the side branch is probably the most important determiner of long-term outcome. Now, I always speak about this, and I think it's very important to realize that it always depends what balloons you are using. If you use a soft balloon, a semi-compliant balloon for lesion preparation, you will not cause a lot of lesion preparation, but you will cause a lot of damage. And this is now just an example of a case where you can see the calcium part of it. It's not actually thick calcium, it's very thin calcium. However, by inflating a semi-compliant balloon in this tight lesion, you then just expand the lesion a little bit, but you dissect into the very healthy part of the vessel, and you don't really touch the calcium. And then you don't have to be surprised when then later your stent opens up eccentrically, and you don't have a nice circle, but you really have this oval formed shape of the stent. So, what are the most important questions we need to answer in bifurcation treatment? I've tried to basically divide it in two pieces. One part is morphology and sizing. I think one of the most important questions is, of course, do you have calcifications, and what is the degree of calcifications? Because I will show you in a case that dependently, if you can tackle that calcification and if you really can do a good lesion preparation, you can continue with the stent, or maybe you should not put a stent. Then the next question, sometimes calcifications can look like thrombus, and sometimes angiographically it's difficult to differentiate between calcium and thrombus. And I think OCT will help you to decide this, because you don't really want to do kissing balloon inflations and all these games when you have a thrombus sitting there. Maybe then it would be wise to say, wait a few days and then come back. And the third most important part, in my opinion, is the sizing. You need to be aware of the size of the main branch and side branch, because very often, in order to create lumen, you need to use big balloons. If you just use small balloons, you will never create lumen. However, you also want to be safe, and especially for our young colleagues, it's very important that by using imaging, you can then decide what balloon size you would be using. And then the second part where imaging plays a role is the strategy you will go. Will you go with a one or a two strategy? I saw in the case before that sometimes you can't plan, sometimes you plan differently and then you have to react. That's a different story. However, it's always good to think about your strategy before you start the case. And then what we need to explore in the future is, because that's also not reflected in the guidelines at the moment, is how can we combine drug-eluting balloons and stents in bifurcations? Because I think this is the next topic we need to tackle in our research and also in our daily clinical life. Which bifurcations we should just combine with one stent and one drug-eluting balloon? Because I think this could be a good solution for such patients. And maybe if we learn how to use these drug-eluting balloons, maybe one day we can also use two drug-eluting balloons to treat some bifurcations. Maybe, of course, not all, but some of them probably are treatable. I would like to share with you the first case. This is a case, a 63-year-old gentleman. I performed this about 3 years ago. He's a family physician. He has an impaired renal function, and he has the chest pain and positive family history. His mother also needed bypass surgery 20 years ago. So, of course, in such a gentleman whom I know personally, I really want to have a good result. And he chose me because he waited also a few weeks. He said, I really want only you. So I wanted to have a perfect result and make no mistake in this gentleman. This is the anatomy of the patient. Now, of course, you could also send such a patient for bypass surgery, but you don't want to do that in someone you like. You would do that maybe with someone you hate. So my strategy here, and I did not use OCT up front because of renal impairment. I said, okay, well, these are two big branches. I will use a 3.0 NC balloon, and we have proper NC balloons here. For the diagonal, I will use also a 3.0 NC balloon for the LED, and then I will go with a mini crush strategy. Now, why not DK crush? I still don't do DK crush because I think the advantage of DK crush is really the re-access of the side branch when you continue with the procedure. And I think the re-access is a matter of how you have prepared the lesion. If you crack the lesion well, then I think you can achieve very good results without really going with the extra step of this DK crush. But that's me. You will see at the end what it looks like. Then two stents. I didn't know the size of the stents back then, but I thought it could be, if I pre-dilated with a 3.0, I'll go with a 3.5 stent. and then I'll do kissing and pot. So we did that. We stented the side branch. I had a dissection. That's why I had to take a long stent in the diagonal. Then I kissed. And then this is what it looked like. Now, it looks okay. It looks okay here as well. But it's a GP and it's a friend and it's someone I know. And I really wanted to be sure in this case that I have a good result. So I did an OCT afterwards, which is not something I do often. Usually I use the OCT catheter procedure, but in some cases I just want the final shot. So in this patient, the OCT actually was okay, but it's very important to realize two things. This is the LAD, just the part distal to the carina. This is the diagonal, just the ostium of the diagonal. And this is the proximal LAD, where you have a big LAD, and then which I potted with a 4.5 balloon. Now, although I used a 3.5 stent, and the LAD looked quite nicely expanded, my diameter in the LAD is not 3.5. It's probably 3.1 here. And then, although I really did everything, I kissed with with good balloons. The ostium of the diagonal is not a 3.5, of course. But I think it's good enough in these very calcified lesions to have, for me to be happy, and the patient has not come back since with angina, and I follow him up regularly. So in this case, I did a lesion preparation the way I do, quite aggressively, and I would like you to realize that although I did all these steps, at the end I had a very nice angiographic result, but the result on OCT is not extremely good. It's good enough to be it's satisfactory, but it's not enough, because in the diagonal ostium, for this big diagonal, I only had 6.2 square millimeters of area. The second case, this is a case I did just 2 weeks ago. 78 years old gentleman, very active, received stents in the LAD in 2007. He has now angina, and he has a problem, recurrent bleeding. GI bleeding, because he has no ox, but he bleeds, and we are planning the left atrial appendage occlusion. Now this is the angio. You can see that the patient has an instant restenosis here from the previous stent. Someone stented even his LAD here, but that's patent. And then he has this ostium of the LAD, and you would usually, like in this case, I would have thought I would pull back the stent back to the left main. However, when I did OCT, I realized, of course, you have here this is after predilatation, the proximal LAD, but then I have this really large calcium ring here, a big, thick calcium. So I thought, okay, well, I'm glad I did the OCT. This is just the ostium of the LAD and coming back into the left main, really big chunk of calcium. So I said, I will prepare the lesion in the instant restenosis with an OPN balloon at 35 atmospheres, 2.5 and 3.0. And then the ostium of the LAD I tackled with a Wolverine 4.0 because I hoped to really create a cut. I then saw, I can't present all the OCT runs. I did another OCT, and unfortunately, Wolverine did not do anything. This is a cutting balloon from Boston. Then I used a 4.0 OPN balloon at 35 atmospheres, and this also didn't touch the ostium. Then I used a Shockwave 4.0 balloon with 80 shocks just in that region, so I can really crack the calcium, because my plan was to use a DB in the restenosis and to stent the left main. However, and you'll see it, I was unable to crack the calcium well. So I decided to treat with a twice drug-eluting balloon, a 3.0 and a 3.5 solution. This is a sirolimus drug-eluting balloon from a Swiss company. Very good results so far. Now you can see here, it expanded nicely in the proximal LAD. It expanded okay in the ostium of the LAD. And then you can see here the IVOS, the OCT, sorry. My area here in the ostium of the LAD is now 7.3 square millimeters. And you can see the calcium ring is intact. I was not able to crack it. I would have, I think, I did not use rotablation, and I don't have orbital atherectomy. I think this would have been a good case for orbital atherectomy to really tackle this part, because I was, in a way, because this is, I think, the reason, wherever I was opening the balloon here, the balloon was going away because it was just in the ostium, and it was not a full ring, but it was a half ring. So I was never able to really apply enough pressure. So that's why. So we can discuss at the end. We will have some time maybe. This is my final result, and I said I use the drug-eluting balloon. Patient will come back. I mean, you can see here the dissection in the left main. So I really tried. But I was not able to open it, so I left it like that. I use now drug-eluting balloon, and maybe if this stays open like this and patient has no angina, maybe this is a better solution than having a stent which didn't open up. Now, I said I have a surprise for you, and I wanted really to share this with you. And it's not a bifurcation. I'm sorry. This is an 82-year-old gentleman with CABG in his history. He has angina and he has a really bad GFR. So cornea angiography was performed by one of my colleagues 2 days previous to the procedure, and the REMA is occluded, and REMA went to the RCA. So 3 days later, I wanted to perform a PCI without contrast. And then this is pure OCT guidance, and OCT was performed with ringers lactate. And I used a 50 ml syringe for manual injection, and like this is the picture of my colleague, and this is the arch I wanted to treat. So I went in here with, I pre-dilated with a 2O balloon, then I did the OCT, and you can see the images are very clear. This is just ringers, no contrast. And then I said, okay, I have the proper size, so I used cutting balloon. First I did rotablation, then I did cutting balloon, then I used OPN balloon. This is, as you can see, a lot of calcium here. And this is the final result, still with no contrast used. And actually, I wanted to, you can see in the longitudinal view, very nice result. And actually, I didn't want to use any contrast at all, because I wanted to publish this case as zero contrast with rotablation. And however, one of my colleagues who was helping me said, come on, one shot you have to do. I mean, his GFR is 15, so let's do one shot. So I said, okay, fine, well, let's do one. And this was the one, and it looked quite nice. So I was happy. And I think this case showed me again, well, maybe we should do this more. You remember the first case, I did not use contrast. I didn't use OCT for preparation because of contrast issues. However, as you can see, you can do very nice images without contrast. I used the guideliner, 7 French guideliner, and was quite nice. So let me conclude. I think OCT will make your life easier and probably the life of the patient safer. Assessment of plaque morphology, as you saw with that calcium case in that bifurcation of the left main, probably is a good thing to know what you tackle before you tackle it. I think using drug-eluting balloons in the future will be probably the way to go. And consider, especially our colleagues who really like OCT, consider using contrast-free OCT because it works. Thank you very much for your attention. Can't hear you. Okay. Rajesh, you are on mute.
Thank you, Dr. Kukli, for nice presentation of 3 cases with a nice demonstration of the OCT. We do have Ankush with us. Ankush has published a paper about use of saline for the OCT demonstration during the PCI. Ankush, any comment about the third case that you did with saline?
I think that was a fantastic case, and that was again a reinforcement of what me and Dr. Rajesh has done together. Like we have done 2 studies. One was the feasibility study that was published in Indian Heart Journal last year by the name of SOCT PCI study, in which we saw that we can use hypernized line, and the success rate is more with right coronary artery, as we just saw with the Dr. Florin case. And again, recently, last month, we had a study of comparison between saline and contrast, in which we showed that when we use a particular methodology, will not have a difference in the parameters when you use heparinized saline in place of contrast. So it's a very well good option, especially in a high-risk patient. Those are at risk of contrast-induced nephropathy.
Can you send me that PDF? It's very interesting. I was not aware. Can you send it so I can I can cite you on because I would like to present this case.
Sure, sure.
So
I'll send you both the studies.
Thanks.
Okay, thank you, Dr. Kukli. As we are running short of time, let me invite Dr. Sai Makbul to present his presentation. Are you ready, Makbul? Please go ahead. Try to be restricted to your time of say 8 minutes and 2 minutes of discussion, please.
Can you see me, sir?
No, we cannot.
Can you see it? Can you see my presentation, sir?
Yeah, we can see one. Yeah, it's coming. Yeah, it's there.
Right, so it's a great pleasure inviting me for this great cardiology conclave. I'll be presenting complex non-left main bifurcations.
Dr. Makbul, you don't make your slide as a slideshow. You go ahead with your presentation without making it as a slide. So I think we can see your slides and then go ahead accordingly. Can you escape the slideshow of your PowerPoint? Yes. Dr. Chopra, we are already running late. Should we wait for the next session?
I think so. I think let's wrap up things here. Yes, some very interesting cases, starting with Dr. Bali and finishing with Dr. Kukli's cases where non-contrast PTCA was done. I think these are the techniques of the future. As older and sicker patients come to our cath lab, we have to keep on evolving. So it was a great session, and I thank all the speakers and Dr. Rajesh for conducting this conference so nicely. Thanks a lot, and let's move to the next session.
So thank you each and everyone in the expert panel and the speaker, Dr. Kukli, thank you very much. And let's collaborate, sir, for one of the OCT projects which we are running at our institute. I will be in touch with you, please. So let me go ahead for the next session, that is about the management of acute coronary syndrome. And let me invite the expert panel for it. Dr. Praveen Chandra is a leading cardiologist and chairman of interventional institute heart disease at Medanta Hospital, Gurgaon, India. He is recognized as one of the leaders in angioplasty in the country and is pioneer in a lot of the new devices and technology of intervention cardiology. He has been awarded with the prestigious Padma Shri Award in 2016 for his significant contribution in the field of medicine. Let me also invite Dr. Basant Kumar. Basant is working as assistant professor in the Department of Cardiology at PGIMER Chandigarh. Dr. Rohit Parthi is a senior consultant intervention cardiologist at Alchemist Hospital, Panchkula. Let me also have the privilege to invite Dr. Elvin Keddy. He is a senior consultant cardiologist at Rotterdam, Netherlands. With vast experience in intervention cardiology, Dr. Keddy is well-known global expert for primary PCI, ischemia, infarction, and cardioprotection. So let's proceed, and let me invite Dr. Keddy for his presentation on ST elevation MI versus multi-versus PCI complete revascularization.
Well, thank you for inviting me. Do you hear me, by the way? Do you hear me well?
Yes, it's visible and you are audible as well.
Okay, excellent. STEMI, non-STEMI, multivessel disease, complete versus culprit revascularization, and how to evaluate that. This has been a question in the last 10 years, and a lot of research has gone here into. So the main question is, it's this Shakespearean question to revascularize or not to revascularize. So let me tell you, this has been an overview of the research done in the recent years. We have three options here. We could revascularize, we could not revascularize, and if we revascularize, we could revascularize doing it on staged or doing it immediately. When we revascularize, then we have to also have other options. Should we do it based on angiography, or should we do it eventually with in-cath lab ischemia detection, which mainly means FFR-guided PCI. Of course, in the new era now, we have also other means like IFR, etc. But all the research performed right now has been mainly with the FFR-guided PCI. So let's go in detail and see what is this concept of FFR evaluation. And the first trial that first proved FFR was the deferred trial. And mainly what this trial is that non-ischemic lesions do well on medical treatment only, while and the PCI of these lesions could be potentially harmful. Then we had another concept, the concept that brought the FFR further on, and that is the concept of transition of FFR from single vessel to multi-vessel. And this is logical because if you have a single vessel and the patient is having pain, that the FFR is negative or positive, you will end up treating that patient. Otherwise, he will still complain of chest pain. But the fame was nice because it brought this concept from single vessel to multi-vessel, and it permitted to us to find which of these causing the pain to these patients, and that's why it that from that moment the FFR become very largely used. And then we have another concept transition in the FFR, a concept that from a tool that differs to a tool that mandates. So till now, till the FAME2, the FFR has been used as if it's negative, you could not perform PCI, while the concept changed in the FAME2 trial and saying that if it's positive, you have to treat. And so this has been the concepts of the FFR. So it has clearly improved clinical outcomes. However, the question with the FFR is if this is the ultimate approach and if it also can be applied as safely in high-risk stable angina patients as well as acute coronary patients. Now, here is the FAME trial 5 years results. And as you could see, the results are stable up to 5 years. The main effects occur early, but they are maintained at 5 years, which means that during the follow-up, after having the initial benefit, both arms are exposed to similar risks. Although it gives FAME2 has shown that it gives a benefit also in myocardial infarction. So if you leave untreated lesions beyond 3 years or beyond 2-3 years, you'll see also an increase in myocardial infarctions, and not only in chest pain. So the deferral strategy remains safe at least 5 years. Medically treated FFR positive lesions will result in major adverse events, including myocardial infarction, despite medical therapy. In stable angina patients, these events are expected particularly after 3 years. And then we had 2 dedicated trials. We had the Dynamo 3 Multi and the CompareAcute. Actually, CompareAcute started early. Dynamo 3 Multi kind of took over this and they finished it early. But both trials looked to one simple question: PCI of the culprit lesion or FFR-guided revascularization of the non-infarct-related artery. Now, it is interesting to show that while the Dynamo Pre-Multi answered this question only, the CompareAcute started actually as comparing not to culprit only. It started by comparing to classical treatment of these patients. So that was a bicycle test or SPECT. And they had a window with which this should have been performed of 45 days. But somewhere halfway of the study, these were translated to culprit only. So it is not clear the strategy that the CompareAcute finally followed. However, both the studies show, in a way, did not compare to what the guidelines at the time were saying, and that was stage revascularization of the non-infarct related artery based on ischemia detection. At the time, the guidelines were already saying that if these non-infarct related arteries had problems, then you have to treat them. But these trials compare it to a culprit, to an only culprit revascularization. So despite that, the Dynamo 3 multi showed an impact on MACE. And that is, of course, that if you leave these lesions untreated, they will have more events. And these events were mainly caused by revascularization benefit, as there were no benefits in myocardial infarction or death. The same here in the Dynamo 3 multi. The effect was mainly seen in patients, in younger patients than in older patients. Although, of course, this could be a statistical gain due to not powered subgroups. The same was observed also in the CompareAcute. These are also, all the events were driven by the need for revascularization. A thing that we've seen basically also, at least, I mean, in the early years, the first or second year of follow-up, these we have seen in all FFR-guided trials, starting from FAME. The main effect we see is the need for revascularization, and with the longer follow-up, though, there will be an impact probably in myocardial infarctions, although we have to say none of these trials were powered for death or myocardial infarction. Despite these randomized trials, there has been, at the meantime, also some meta-analysis or smaller retrograde analysis. So all these studies has looked to one question: is it safe to perform to perform FFR-guided revascularization? And is this FFR-guided revascularization in acute coronary syndromes as safe as it is in stable angina, as we have seen where it was first approved for? And in fact, these studies show that looking for MACE, myocardial infarction, revascularization, or death, all events are higher with a deferred revascularization in acute coronary syndromes. All these different studies that I showed you point to the same. Either there is more ischemia-driven revascularization, there is more death, there is more myocardial infarction in these patients with acute coronary syndrome as compared to stable coronary syndrome. And it is also so that as it comes closer to the value of 0.8, the events gets higher. And I will explain you in the slides later on why this is the case. So study after study, we've seen that there is a relationship between lower values of FFR and events, as well as acute coronary syndrome and events, and these are higher in acute coronary syndrome when deferred than stable angina patients. And this was the case till we had this larger, very nice study that basically gives a bit the approach that we have as interventional cardiologists. They had patients with myocardial infarctions, these were STEMI in fact, and the very large number of patients. They had almost about 4,000 or 5,000 patients, and they randomized into culprit only or randomized based on angiography, if angiography was more than 70%, or for lesions that were between 50 and 70%, the use of FFR was allowed, and for these lesions, the FFR was used. So there was a clear clinical outcome in improve of death and myocardial infarction with a reduction of 26%, absolute reduction in death and myocardial infarction, where there was a 50% win, so a very strong impact, a number needed to treat of 13 patients to improve death, myocardial infarction, or ischemia-driven revascularization. The question is why this happens, and there is a combination of anatomy, physiology, and biology. And when I'm talking about biology is that the events happen also not because the lesions are ischemic, but because the lesions rupture and heal. And I'll come back to this previous slide. Look at the impact of in the treated lesions, so the blue line. Also there, the events go up. The events go up, and it's something that we see that around 2 years, we're close to this 7% death or MI, something that we've seen in ischemia trial. And in fact, to all the other trials, there is an initial phase of myocardial infarction, but it does not stop there. They keep going on. And there is because also in the lesions that are not treated, there is, due to deferred based on FFR only, there is still progression of plaques that will lead you to have new events. In fact, this is a sub-analysis I performed. A good colleague of mine, Dr. Natalia Pinilla Echeverri, she did an analysis. And she did an analysis showing that, in fact, what they called obstructive lesions here were 70% lesions. These lesions, they will have a higher rate of TICFA on a patient level and on a lesion level. But it is very important to show, and I'm showing you this, what they don't point out is that using a deferred FFR lesion, there are more of these high lesions left untreated than those who were treated. Look here, there were in the group that were obstructive lesions, there were 58 TICFAs, where there were 74 left untreated. And they also state that 31 of these obstructive TICFAs were in minimum lumen area more than 2, a value that represents FFR negative lesions. So it means that these lesions were left untreated. And in fact, there are some data where we're looking to the numbers of the deferred, the group of Escanet and Chirato showed recently this very nice trial published in JACC Intervention, when they compare that the values of the deferred and those treated of ACS are pretty much similar, but that there is also clearly a different outcomes in ACS with stable angina and then with those of stable angina, angina pectoris. And this is also very higher in these patients as these ACS patients progress faster. So this combination of anatomy, physiology, and biology is what we need to look to improve MACE. And I'm showing you another very interesting study. A study that was done based on CT and then from a group of Korea and Japan. Very nice study in my opinion. It shows you the real numbers of how our deferred FFR strategy is working. And that's what they take is they do a CT scan of all patients and they look to, and then they perform FFR. And as you could see, as we always see, 1/3 of the patients were FFR positive and 1/3 of them were FFR negative. But if we look to what is important into progressing is minimum lumen area, there are almost as much lesions remained more lesions remaining untreated due to an FFR positive than lesions that were treated due to an FFR that was positive. The same can go for the plaque burden, and the same can go for low attenuating plaque. Interestingly, this study showed that as the FFR becomes significant, so the plaque becomes more vulnerable, and that is logical because the plaque progresses by rupture and healing, and that will bring you at a certain point that future ruptures and healing makes this plaque more vulnerable to the future rupture, and that is also makes the lumen more narrowed, there is more progression, more diffuse disease. So it is clear that these will give you, the plaque becomes more vulnerable as it's ischemic. But I want to show you these numbers. Look at these numbers of 3 vulnerable features, concomitant 3 vulnerable features. Twice of these plaques are left untreated due to FFR negative, while only 1/3 is being treated. And in fact, the lesion does not rupture and heal because it's ischemic. It ruptures and heals because it's vulnerable. And also here, look at during the follow-up, the number of events based on the of these lesions with high-risk plaque. And you could see that there are 16% for the FFR that was negative and that could be treated. But look at this here. Although these were not FFR positive, the majority of events are coming from these lesions. And it becomes even more clear from the same study here. Look, the blue line shows the events comes to the deferred lesions. There are 15%, while here 10% of the events come from the revascularized. So you could have an FFR negative lesions left untreated that have 15% event rate, where an FFR treated will give you less event rate. And while you do not have high risk plaques, then only these events are lower. And this translates also here, you could see it on this side, these high risk plaques will give you more events. However, the total of events that coming from these vulnerable plaques is much higher than those that were treated. And this is the new way of thinking we're having right now. And this leads us to the PROSPECT 2 trial, which looked to the vulnerable nature of the plaque based on NIRS, which shows the lipid in the plaque. And they looked to a primary endpoint of cardiac death, MI, unstable progressive angina, pectoris in lesions that were not treated but were not in a naturally history followed. And what they showed is that a combination of a lipid plaque with a plaque burden more than 70% had clearly a higher event rate than those without. And the same did also combine, but combine took lesions that were actually angiographically already intermediate between 40 and 80%, and choose diabetic patients because these are the ones who progress. And we looked to people with versus without TICFA in FFR negative patients. And what we showed is that also here, now we could clearly find the lesions that are probably prone to progression, and they are prone to progression with a factor of 5 times more. So similarly to what this Japanese and Korean study showed, also we looked to a 1.5-year event rate of 13.3 in patients with TICFA versus very low rate in 3.1 with patients without TICFA. So, and these were basically driven from myocardial infarctions and clinical driven revascularizations. So in conclusion, I want to show that FFR-guided revascularization is currently the best way to guide revascularization in the non-culprit lesions in acute coronary patients. However, incorporation of imaging and the revascularization strategy may improve clinical outcomes in acute coronary patients, coronary syndrome patients. Thank you.
Thank you, Dr. Edwin. Dr. Chandra, for any comment?
Yeah, I think, this was a very, very comprehensive and, educative presentation from Dr. KD. And I must say that, certainly this approach of FFR-guided intervention of non-culprit vessels is gaining a lot of ground based on all this information which is available, these, evidences which are available. And I think with the last study, which was the complete study, maybe it's time that most of these cases, and we see multi-vessel disease in at least 50% patients, in Indian patients. I'm talking of Indian patients. And I'm sure most of the cath labs which are doing PCIs today are more than 50% of these procedures are actually done in acute MI and acute coronary syndrome. So use of FFR in these labs, I think, is quite important. And so it should be much, much more used than what it is being done now. to improve the outcomes in these patients and to really, demystify the whole question of whether we should treat one vessel or two vessels or three vessels.
Very nice. Thank you, Dr. Edwin. And now let me invite Dr. Anil Dal for his presentation on physiological assessment of residual ischemia after successful PCI. Dr. Dal is the leading cardiologist of India with more than 30 years of experience in the field of intervention cardiology. He is an eminent teacher and proctor in many national and international forums. He was awarded the Sena Medal for his distinguished services to the armed forces in 2005 by the President of India. He is currently working as a professor at the Department of Cardiology at JSHS Hospital, New Delhi. Dr. Dal, please.
Thank you, Rajesh. This is really, as Praveen said just a little while ago, we need to demystify a lot of mysteries. And I was very impressed when Florim Kukuli actually pointed out that the lumen should hold the results because it's all anatomical. And Elvin, as always, summarized that it is not just the anatomy, it's also the physiology and the biology. And really, if we take this any further, it'll be very simple to go back to Andreas. And if you recollect, one of the things which is said about Andreas is the person who funded Andreas's work was Ake Senning. And when he walked into the cath lab, when Dolph Bachmann was having an angioplasty to the proximal LAD, and when there was a pressure gradient which was studied, he said, oops, this is going to work. And why? Because we are now treating not just anatomy, but also physiology. Of course, we have to better that yet again with imaging and our understanding of biology and our understanding of pharmacology. That is something which we need to add. But really, clinical outcome is determined both by the extent and severity of ischemia. And we know this very clearly from Hakamovich's data, which actually tells us that 10% of ischemic burden is somewhere wherein revascularization would benefit a patient for improving quantity of life as well as quality of life. I know that the ischemia trial changed and shifted its goalposts from 10% to 5%. However, the severity of disease is also very relevant as our understanding of what is vulnerable. And for all those who have not seen it, I would recommend that they see the YouTube video of Elvin's presentation on the vulnerable plaque, which is very, very elegantly done. But even after PCI, we do get recurrent angina in about 20 to 30% of cases. And this has happened all the way down, regardless of our improvement in physiology, regardless of our improvement in our stent composition, in our drugs. We also realize that it is existent even when thinner strut, sub 70 micron strut thickness, improved geometry, biodegradable polymers, and having an abluminal coating. And even if we base it on physiological assessment, this remains actually a reality. And this is something which needs us to introspect. What are the reasons which could happen? Well, simply stated, the coronary artery disease could be diffuse. There could be other lesions. We as cardiologists would like to think that our stent was underexpanded. We had a geographical miss. We had a tissue protrusion, edge dissection, malapposition. But also the estimation of FFR, we should not forget things like vasospasm, accordion effect, and drift. I've seen FFR being done so often where drift has not really been accommodated. But we have to introspect, are we doing a good enough job? And if we look at the combined data of FAME1 and FAME2, and Piroth actually did a meta-analysis of all the post-PCI FFR, and we put them into tertiles, which are based on the post-PCI FFR. We found that by multiple regression analysis, lower post-PCI FFR happened in male gender, diabetics, LAD location, multiple stents, and the higher post-PCI FFR was obviously when there was a higher baseline FFR and a higher diameter stenosis. Now, this was all tend to taking a potential cutoff value and a potential post-PCI FFR of 0.92 was thought to have the best cutoff in terms of a 75% sensitivity and some specificity which was there. But Agarwal actually looked at about 574 real-world patients, about 670 odd lesions in one center. This is a single center, and looked at patients who had 21% had post-PCI FFR less than 0.81 despite angiographically satisfactory result. And when there was subsequent optimization, post-PCI FFR increased from 0.78 to 0.87, and this was a very strong independent predictor of MACE in the long run. Adeleti reported FFR search registry and actually complemented the low FFR, which could have a higher MACE, by doing an IVA sub-study, which revealed focal unstented or underexpanded lesions, and this was again taken into consideration. Let us bring this back to our understanding of FFR. We have to understand that 0.8 FFR has been used in all, whether it was used in all the trials, but really the conceptual plot for FFR is that it is a continuous marker of risk, and even post-PCI FFR remains a continuous variable, not just having one discrete binary number. A lower post-PCI FFR definitely correlates with adverse events, and impaired post-PCI physiology has increased long-term MACE, whether we estimate it by FFR or post-PCI PD by PA, which could be taken even less than 0.96. And if we add post-PCI physiology, we get incremental prognostic value to our baseline clinical model or angiography, which is being used. So one lesson we have learned is that post-PCI physiology is important, and if it is low, then it is associated with worse long-term outcomes. The ERIS study looked at this and found that it was being used in less than 10% of lesions which are investigated with pre-PCI physiology, which is very strange because the cost of the FFR has already been undertaken. And why this is so is because physiology was used in limited number of cases. There was no RCT and no clear instructions and cutoffs for its use. You needed to administer adenosine several times. You needed to have a post-PCI. You needed to complement it with imaging, and the reproducibility was a challenge. Even with good angiographic results, Agarwal had shown 21% did have a residually post-PCI FFR was low. And the same thing even in ACS situation, there was a paper by Kazula who actually showed that there was a significant residual ischemic FFR. So questions remain. How should we define it? What is the next step? Should we do imaging? Should we benefit the patient if we optimize? What is the cost? And do we have an RCT? And Agarwal actually tried to give an algorithm for this. We tried to look then at the FFR pullback, because hyperemia amplifies gradients and the signal to noise ratio is improved. So if we actually don't do just a classic FFR but do an FFR pullback, we may actually be using it even better. But then we moved on to some of the newer modalities, and this was realizing that there were non-hyperemic indices which could be used, which are dependent on the wave-free ratio, and all these ratios, the instantaneous wave-free ratio, was utilized by one company using what is called IFR and several other companies using DFR or RFR, which actually was validated by the Defiant Flare and the Sweetheart as being equivalent to FFR. And even by just purely anatomically guided CT FFR, we now have good data that this CT FFR can hold good, or QFR can hold good as far as FFR is concerned. But what about our trials investigating post-PCI physiology? Like I said, we had the PIROT data with FAME1, FAME2. We also had some data from DK-CRUSH 7. And then, of course, we had angiographic data from Agarwal. But what we realized is that we had to shift from a binary interpretation of physiology as being positive or negative to being a quantitative site-specific one. We used PD by PA, and we realized that there was a discordance between post-PCI resting or post-PCI PD by PA and FFR. And if we used IFR, we could actually have a more cost-effective strategy because we were using less adenosine. And this after defined flare, we had moved on to a study called defined PCI, which in my opinion is one of the most relevant studies in the last 2 years. So defined PCI used about 500 patients with successful PCI and qualified IFR pullbacks and demonstrated that 1/4 of patients who we thought angiographically had pristine results had significant residual physiological ischemia with post-PCI IFR of less than 0.89. Variety of case examples. We looked at the pre and post-PCI, and we realized that this gain was difficult to predict based only on angiogram. The focal pressure gradient could be instant. There were 93 patients, vessels with focal disease, which had significant residual pressure gradients. There was some physiological miss, 31% proximal to the stent, 30% distal to the stent. And if all residual focal lesions could be treated, the rate of significant ischemia could be decreased from 24% to 5%. This is a big deal. And really, just to summarize, that 24% had post-PCI significant FFR, variety of conditions. We looked at that, marked a point that imaging was not mandatory in defined PCI. Only a few centers used it. And normally 1 in 4 patients would leave the cath lab with post-PCI residual ischemia of IFR less than 0.9. And this could be in about 80% untreated focal stenosis, which could be treated. 2/3 were proximal or distal to the stent, 1/3 were inside the stent. And this was a great opportunity for improvement. Well, this was with IFR. And the target FFR used a similar approach to try and understand that whether we could do this with FFR, demonstrated the same steps with target FFR. 32% had an FFR of more than 0.9 and 29% had an FFR of 0.8. And this, so another lesson was that a post-PCI resting physiology pullback can unmask angiographically occult lesions that may benefit from additional PCI. We may turn around and say, we are using a lot of imaging. Yes, imaging will help identify, but what if you can, to see clearly and treat optimally, you can do an IFR co-registration. And this is an advanced physiological guidance which can help you not just whether to treat, but where to treat. And by this, we moved on to a concept of precision PCI. We understood that ischemia attributable to individual lesions could be identified. For example, in this so-called diffusely diseased vessel, we could know where the step-up gradient was, and treatment decisions could be based whether we were dealing with focal disease, which would benefit with PCI, or diffuse disease, where there was, or diffuse or distal disease, where there was a unlikely to be any benefit with PCI. This could help us plan PCI strategy based on IFR pullback. We could understand that diffuse disease may require non-interventional mechanisms, maybe using aggressive lipid lowering, PCSK9 inhibition, so on and so forth. The same thing could also be done with a pullback pressure gradient, and we could actually do a virtual FFR with a pullback pressure gradient to identify that treating proximals would probably be, with focal disease, would be more beneficial than treating distal, diffuse, and small vessels. And for this, the precision PCI with imaging and physiology guidance could actually optimize pre-treatment strategies, optimize complete treatment, and minimize MACE, which was mistakes using angiographic coronary evaluation alone. So all this has recently been put together in a JAK intervention algorithm, which actually says that regardless of the tool you use, you must look at physiology and imaging post-PCI so that we can have great results, and our results can be comparable with those provided by our surgical colleagues. What about QFR? Well, we have a trial with Hawkeye QFR, which is actually looking at a precision PCI kind of approach, even with QFR. And therefore, this is a concept which is going to come to stay. Remember, if 1/4 of the PCI that you are leaving angiographically is going to have suboptimal results, it doesn't portend well for the therapy. So physiological assessment predicts outcomes, is not used very frequently. It can identify stent-related issues, overlook lesions and diffuse disease. Focal drops may indicate some treatment, either post-dilatation or another stent implantation, maybe use of DEB. Diffuse therapy disease demands aggressive medical therapy. Maybe there will be a role of DEB here in the future. We are not sure. And we are looking at some powered trials comparing physiology and angiography, like the FFR React and the target FFR. And really, we are waiting for the defined GPS, wherein patients are going to be randomized to either a GPS-guided PCI or an angiographic-guided PCI. And we're going to see if the GPS-guided PCI with a precision PCI approach will actually be beneficial for our patients. Thank you very much for your kind attention.
Thank you, Dr. Dhal, for a wonderful presentation regarding a newer aspect of use of FFR in post-PCI patients. Till now, in a routine practice, we were only doing the imaging to look for, say, stent optimization. Now it's the stent optimization anatomically by imaging and functionally by FFR. That is something great. My two queries about what about the culprit vessel revascularization in acute coronary syndrome, and is there any role of FFR when there is a distal microcirculation problem and you can have an overestimation? Is it the same 0.90 FFR for this patient as well? And the second query is about, say, discordance between imaging and FFR. Is there any subset of the patient where then there can be a discordance between the two?
So thank you, Rajesh. Very, very good questions, as always, very intuitive of you. My purpose of actually this presentation is to point out that this FFR was oversimplified. And it was oversimplified because calculation of CMR, CFR, and FFR was too complex a process. So, but the danger of oversimplification is that we forget that it is not a discrete variable, it is a continuous variable, and we should not forget the clinical circumstance of the patient and should not use a 0.8 cutoff. In fact, I think the most important slide of my entire presentation is to show that FFR is a continuous variable. You should not take away the understanding of the clinical situation. If you have a patient who has got an ulcerated plaque, who's got symptoms, and an FFR which is non-ischemic, and if you leave this and this patient comes back to you with a deferred MI, you are only yourself to blame because you actually did not look at the clinical profile or did not take a holistic view of the situation. And we've all had these cases wherein we kind of went on a binary number and said we will interpret it. So this is something which needs to be completely factored, and we will have more results from the defined GPS, which will answer the second half of your question.
Dr. Chandra, any comment about?
Yeah, I know. I think as Dr. Dhal always gives very nice and educated presentations, and today also we learned a lot from this FFR based interventional approach, and in the first presentation and also in the second presentation, I think using IFR. So I just want to add one thing, that the algorithm is rather very simple now, that you can, since both these machines have both these options of FFR and RFR. So you can just put the wire inside, do a RFR, and if the RFR is positive, you don't even need to do a FFR in those cases. And then the second step is to do a contrast FFR. And then if the contrast FFR is positive, you can stop at that stage. And if the contrast FFR is negative, then you can do a adenosine FFR in these cases. So this is a very practical kind of a stepwise approach in using the physiology, and I think it works out quite well, and it saves time, it gives reasonably good outcomes.
Great point, Praveen, but we have to just see that we should respect anatomy, respect physiology, and also respect the biology and pharmacology. So that's the only point which I was trying to make, that keep our eyes and ears open. We could do a better job than what we are doing.
Absolutely.
Thank you, Dr. Dal. And let's move forward. Let me invite Dr. Parag. He is Associate Professor in the Department of Cardiology at PGI to have his presentation on management of acute coronary syndrome patient. Dr. Parag, please.
So, a very good afternoon to everyone. After 2 long lectures on what to do, what not to do in patients of ACS, prior to taking them for a PCI, while doing a PCI, and generalizing the results to the complete world, I would like to bring you back to a patient case-based scenario where a young patient had a massive MI, and how you should go about it when you are faced with such a difficult situation. So a 34-year-old male who's a heavy smoker had a chest pain since 4 hours. He was having severe diaphoresis and hypertension. He was also looking confused. His ECG showed an acute anterior wall ST elevation, MI from V2 to V6. In all, he was also having an ST elevation in 1 and AVL. But there was also surprisingly ST elevation in 2-3 AVF also, which brought some confusions to the diagnosis, whether this is an MI or not, but the clinical scenario was looking like completely an MI. He was brought to PGI emergency and immediately was shifted to the cardiology coronary unit and was planned for a primary PCI. In view of his hemodynamics, which were compromised, he was immediately shifted to the cath lab. His right femoral artery was punctured and the BP was 70 systolic, and he used to have recurrent runs of ventricular tachycardia, in fact ventricular fibrillations, for which he had undergone 3 cardioversions on table while performing a PCI. So this was his angiogram when a left coronary artery catheter was hooked, and it was found that he had an ostial LAD block. There is a slow flow in the circumflex. The heart rate is also on our lower side because this was a post-DC cardioversion angiogram. So we immediately took an EBU catheter. We hooked the left coronary artery. We didn't take a check shot on the right side, and we passed our wire. Immediately after passing the wire, we could see that there was some amount of contrast flowing across the vessel. And after doing this, we did a quick balloon dilatation and a stenting of 3x38 stent across the LAD. Not more than 2 steps were taken before this procedure was undertaken. And immediately, and as the patient had 3 episodes of DC cardioversion in between, we had to put a TPI also because there was a heart rate on the lower side. And immediately, IABP was also inserted in this patient. But what we could see is that after waiting for 15 minutes, his hemodynamics was not improving. And we thought that whether we are missing something or not, then immediately what I thought that let's take a check shot of the right side. And what was happening on the right side was also there was an acute MI in the right side. The right coronary artery was also completely blocked. We took another guide, we passed a wire, the flow was established in the vessel, and immediately a 3x33 stent was also again placed in the right side, and we could achieve a very excellent result with that. The whole procedure has happened only in 30 minutes, and we have used not more than 60 ml contrast in the whole procedure. We used GP2B3 infusion for in the whole day after the procedure, and post-procedure there were multiple runs of BTs and BF in the CCO requiring cardioversion. Patient was managed with xylocaine infusion, was extubated on day 2 of the procedure. However, later on, we also evaluated for the causes of MI in this young chap, and it was found that except for smoking, no other cause could be determined. There was no dyslipidemia, no family history of any coronary artery disease. There was no reason why he could have embolism in 2 territories. He recovered in next 5 days and was discharged on day 7 with an, and he came back to us multiple times after that, and he has an ejection fraction of 45 minutes. So overall, this is what my case-based scenario is, and I would like to actually bring up important fact in front of everyone that when you are faced with a situation that you are not able to explain the patient's symptoms with one MI, very rarely you will have associated MI on the other territory also. And you need to be vigilant about that. And the most important thing, you need to be very fast. If you keep on thinking, you take time in decision making, probably we may lose the patient in that amount of time. And the take home message is we need to be quick in terms of decision making in MI. We need to have a quick interventional hands. We should not be a coronary beautician performing good job, excellent job, giving a pristine looking coronaries, but not a live patient. And we should try to find out the cause for addressing it for the future so that the patient doesn't have an MI later life. Thank you. That's my case is all about.
Very nicely performed. A case of acute MI with two infarct-related artery, RC and LA, which were totally occluded. What's the reason here? Could you evaluate it for, say, hypercoagulable state in a young fellow who is 34-year-old and not a smoker?
We have evaluated him extensively. Antithrombin 3 deficiency, protein C, protein S, APLA workup, everything was done after 6 months. We purposefully delayed all these things for 6 months, but we could not stop his antiplatelets because antiplatelet needs to be stopped for certain investigation. But whatever investigation we could do for his 2 MI simultaneously, we could only attribute it to smoking. We could not attribute to any other cause.
Dr. Chandra, Dr. Dal, please.
So, Parag, as always, very brave of you and done a great job. But by any chance, did you look at a PFO?
Yeah, we purposefully, I have written in the slide, no reason for an embolism. So for that, I have seen for the PF also. I've seen for L appendage clot, but
I can see Julio here, and maybe we could ask Julio if he has ever run into anything like this.
Sometimes yes, but not only in people with disturbance in coagulation. This was a heavy smoker. Sometimes you have a simultaneous rupture plaque. And so that was a very lucky case to be brought to the end. And perhaps one of the messages also when you have one artery block, have a quick check to the other ones because you have a full picture in just a few seconds. So that could be another message.
Great. Lipoprotein small a was normal?
Yeah.
Yeah. Okay.
Okay, Parag, thank you very much. And let's move forward. Let me invite Dr. Ankush. He's going to talk about application of OCT in bifurcation angioplasty. Dr. Ankush, a PGI alumnus, is currently working as a head of department cardiology, military hospital, Jaipur, Rajasthan. He is expert in complex bifurcation PCI, also the CTO1 with and without imaging and functional assessment. He has an expertise also in the structural heart disease and arrhythmia treatment. So, Dr. Ankush, please.
Are my slides seen?
Yes, we can see your slide and can hear you very well.
Thank you, Dr. Rajesh, for giving me this opportunity to see how we can use OCT in bifurcation angioplasty. We'll be seeing that what should be done with OCT during bifurcation angioplasty and what should not be done. So bifurcation lesion angioplasty accounts for around 15% of our daily routine angioplasties, and it has got a high risk of complication like side branch occlusion, stent thrombosis, restenosis. Let me show you one case. This was a 55-year-old female. She came with STEMI. As you all can see that this was a significant left main bifurcation lesion, Medina class 111. So we thought to go ahead with the OCT image. Let us see what we saw. So when we did the OCT, so let us see when you have got a bifurcation lesion, how OCT can help us. So this was a OCT run from left main to LAD when we assess this. So whenever we are dealing with the bifurcation lesion, let us see how OCT can help us. So this was the left main, this was the LAD, this was the ostium of side branch. So angiographically, the ostium of side branch seems to be diseased. Medina class was 111, but here you can see there was not significant stenosis. One of the studies showed that if you have got a cranial tip angle less than 50 and the cranial tip to branching point distance less than 1.5 mm, this is the risk factor for side branch compromise during angioplasty. So whenever we are planning for provisional strategy, we can make ourselves sure or confident that this side branch is going to get occluded, or we are going to have a complication with this side branch or not. So in this particular case, the angle was 70, the CT BP length was 2.5, 2 mm. So we went ahead with the provisional strategy and we placed a stent from left main to LAD 3.5, 32 port with the 4.5. You can see the result, and you can see the well flowing T-meter flow across the LCX as well as in the small ramus also. So when we analyze the OCT post PCA, in post PCA, as you know, we have to look for the stent complication. We have to look for the edge dissection. There was no edge dissection. There was well opposed stent and the well expanded stent also. So when we are dealing with the bifurcation provisional strategy, we have to look for the side branch ostium. So one of the studies that showed that if we have got a link-free side branch ostium and you have to go for kissing balloon inflation, so in provisional strategy, this is the ideal. This is the example of ideal side branch ostium because you have got a link-free ostium and you can go to the distal wire. You can recross through the distal stent studs. So one of the study done by a Japanese operator, they showed that if you have got a link-free side branch ostium and you are able to go ahead during the kissing balloon inflation through a distal stent studs, you will have a less amount of inappropriate stent apposition. You will have a larger ostial stent branch ostium during follow-up. So idea is whenever you have got a provisional stent strategy, go from the distal stent studs so that you can have a minimal metal. When you will go from the distal stent studs, you will oppose these stent studs to the wall and you will have a less amount of metal at carina. You will have a larger side branch ostium and you may have a more better long-term outcome. So many studies have been done in which it has been shown when you have a link-free ostium and you go distally, you will have a larger amount of area at the side branch ostium. Though this has not been shown to be effect on clinical implication, like one of the study that was done by Omura that showed that there was no significant difference between the ISR at 9 months, but still maybe long-term outcome may be different. So this was the side branch ostium pre and this was the post. This was another case, 70-year-old male. He had a interstitial lung disease, again a bifurcation lesion. When we did a pre-PCI OCT, we showed that this was the left main, this was the LCX region. We came to know that the CT angle is 65, CT BP length is 2.1. So we were confident that we can go ahead with the provisional strategy. We also saw that in the mid-LAD there was a heavy amount of calcium. We did the calcium score, it was 4. So we went ahead with the rotablation. Then we did a PCI from left main to LAD. This was the result after left main to LAD PCI. You can see well opposed stent. This is the apposition indicator. 99%, 98% of expansion, no edge dissection, and the minimal stent area was 9.9. So when we saw the side branch, here is the link. So this is the subset that was shown in the study that we will have a suboptimal side branch result. So as far as link-free side branch ostium is concerned, we cannot control that. Either you'll have a link-free. It has been shown in studies that there are 50% of chances you can have a link-free side branch ostium. The only thing that we can use as far as OCT is concerned is 3D reconstruction, and we can try and go distally so that we have got a minimal carina at minimal metal at carina and better long-term outcome. This was the pre and post side branch ostium, and this was the angiographic result. So let me show you another interesting case. This was the 50-year-old male. He came with a crescendo angina, significant left main bifurcation disease, mid-LAD CTO, RCA was normal. We went ahead with the retrograde technique and opened the mid-LAD CTO with the reverse card technique. This was the final outcome after mid-LAD CTO opening. Then this was the left main bifurcation disease. So we wired both the vessels. Then we did pre-PCI OCT. With pre-PCI OCT with 3D reconstruction, you can see the entering of your wire in the side branch. You can see what kind of morphology. So for me, the most important thing that I look for in a pre-PCI OCT is the morphology of the
morphology of the lesion. So in this particular, it was a fibrofatty lesion. I know that with non-compliant, it will be more than enough. Then we went ahead with pre-dilatation. These are the dissections. So we went ahead with the DK crush technique, pre-dilated the LCX, and then pre-dilate the LCX ostium. Then I placed a stent in the OM and in the LCX ostium by keeping a balloon in the left main to LAD. These are the steps, detailed steps of DK crush. Then placed the side branch stent, crushed it, then first rewired, then did the first kissing, then placed the stent in the main branch from left main to LAD, then recrossed it. Then recrossed it. So first did pot, recrossing, then final kissing, then repot. And this was the final result. So this was the final result. So in this particular case, we have done DK crush, 2 stent strategy. We have done final kissing also. Let us see what we saw in the OCT. So this was the LCX well opposed stent, well expanded stent. And when we saw this, this was the left main to LAD stent. This is the overlap segment. This is the diagonal opening, and this is the LCX opening. So this is the LCX opening at final stage. Let me be very truthful to you. I left it at this point. This was the final shot, final OCT run, and angiographically we were very happy. But actually what happened, there was large amount of stent stretch, and we left it at that point. So this patient came to us 9 months down the line, and just see. There is side branch LCX ostial ISR. So when we compared it in April 18, when we did DK crush left main bifurcation angioplasty by DK crush technique, we left all these stent struts. So again, the point here is when you can use OCT with you can use OCT while recrossing the side branch, and you can recross distally so that you have minimal metal at carina. You have got less stent struts that are hanging in the side branch ostium, so that you will not have these kind of ostium. So this was 9 months down the line. These were the stent struts after final kissing. I left it at this ostium, and this was the outcome. That side branch ostium was completely occluded. So what is desired? This is from left LCX, and you can see totally LCX was totally occluded because of the hanging stent struts that I left. So when you have done, you are doing 2 stent strategy. You take a final run from main branch, see the ostium. If you are having stent struts hanging, you should oppose it. You should inflate it with a larger balloon so that you have you don't have these kind of hanging struts and these kind of long-term outcome. So what is desirable? This is the case in which I did a LAD D1 bifurcation and then bailout left main bifurcation. This is the kind of result.
Can you briefly conclude it because we are running?
So this is the kind of result that one should get when you are doing 2 stent strategy. This should be the kind of ostium. Thank you very much.
Dr. Julia, any comment about, say, struts being hanging across the side branch at risk of instant restenosis? We in the routine practice do go ahead with a single stent from, say, left main to LAD without dilating the ostium of the left circumflex. But then most of the time it's a check angiogram, everything is okay across the L6 ostium. Here Ankush has demonstrated that overhanging strut across the L6 ostium is the reason for the instant restenosis.
Correct. In a 2 stent strategy, that should not be left like this.
Okay, that is a challenging, and we needed to get some specific tool not to scan the entire vessel one additional time to be informed about what we are leaving at the branches. Of course, the best when you are doing such a similar procedure with the 2 stents, it's to have the pullback in both vessels, but this is something that sometimes is also unpractical. But the suggestion is to have the full pullback coming from the LAD and the circ when you are doing such a similar cases. You can easily imagine this point and eventually correct.
Dr. Dal, any comment about?
I think I'm always in awe of this work and all the good things which Ankush does. It really makes us think about what we've been doing without using so much of OCT. But I just want to ask Ankush whether a comment made by Dr. Kukuli a little while ago was that he does not use DK crush. And this is a feeling which I've had for many years, is that if you use imaging in both the parent and daughter vessel, in both the vessels, and if you are using imaging to guide your procedure and to end your procedure, then a mini crush would have the same results as a DK crush. So I think this is something which can be part of a larger collaborative study. We have Julio here. So because the only one great advantage which DK crush gives us is not only in many steps to a procedure, but is basically to ensure that we can recross. So your comments, Ankush, and maybe Julio, your comments too.
Sir, thank you very much for your great comments. The only thing that I want to emphasize in this last case was when you're doing for a two-stent strategy, either mini crush or a DK crush technique, we should not leave the hanging stent starts with the link at that point because we are not doing the purpose. So we have started doing two-stent strategy because we are thinking that this has got a significant disease in the side branch ostium. So when you have done final kissing, then I think we should not leave this much amount of stent starts because this
your point taken completely. But I'm saying a comparison between DK crush and classic mini crush. Of course,
you're absolutely correct. You're absolutely correct. But the only thing is that
to optimize the side branch with a balloon.
I'm a strong believer as for bifurcation angioplasty. One should go ahead with the technique one is more comfortable with. Number one, beside all angles and dots. I believe that DK, like when I started doing angioplasties, I'm more comfortable in DK crush and data also shows that with DK crush you have got a better outcome, you have got a better side branch access also.
Thank you, Ankush, for a very nice demonstration of OCT for bifurcation PCI. And let me now invite Dr. Julio for his presentation on OCT-guided decision-making in complex coronary disease. Dr. Julio, also known as Dr. G, am I correct? Dr. G is the Director of Clinical Research Program at Interventional Cardiology at Bergamo, Italy. He has a long-standing research expertise in coronary intervention, particularly in the field of high-resolution intravascular imaging, especially OCT, those with acute myocardial infarction and stent vascular biology. Dr. Julio has authored publications in various cardiovascular research and clinical trials across all the prestigious cardiology journals. Dr. Julio, please.
Okay. Rajesh, thank you very much for inviting me. It's really a pleasure to be here with all of these Indian friends. The more and more we are going to the table with such a similar cases where the complexity is everywhere. You can see example of left main, diffuse calcification, diffuse disease. We listened a few seconds ago, the major bifurcations, CTO, and then in-stent restenosis. So this level of complexity is not only anatomical, but many times is linked to comorbidities, likewise to have diabetes, renal insufficiency, impaired ventricular function, and then is asking for more specific intervention and a dedicated tool. So there are two increasing needs in current PCI. One is to understand better the type of complexity by using hemodynamic and imaging. The second one is to have in guidance online of the intervention. What OCT is doing? Number one, it stays strongly linked to the angio because we are using angio. And so the level of precision that we can guarantee is reflected with angio co-registration on the screen. Second, is bringing automatic measurements instead of visual interpretation. Is telling you the size, is telling you the position, is telling you something about the optimization, and then is quite easy to be used by a single operator. In which way OCT might impact the decision-making complex disease? Well, first of all, it's telling you the type of lesion you are confronting, not in a single cross-section, but in the segment you want to treat. And if you have lipid or fibrotic, you can go one way that is quite easier in terms of lesion preparation. And the more you are increasing the complexity of the lesion, and the more you have plaque burden and resistant plaque burden, including calcify, the quicker shift to a more aggressive lesion preparation by using different type of device. Of course, on the way during the procedure, when your angiographic results seems to be pristine, OCT is telling you on the suboptimal results. Likewise, the distal dissection or the larger malposition that you can quickly go back and correct. We saw a few examples some seconds ago, how when you are confronting with a suboptimal results, perhaps less left before, you can go back and correct by using some innovative 3D visualization of the vessel for optimizing the procedure. How OCT might change the strategy and might have impact on the clinical outcome, I think you will see at the end of my presentation. Let's try to have some anecdotal case at first for explaining how we are working. This is an acute coronary syndrome coming with left main. And you can see very uncomfortable. I was working not in my cath lab, but in an Indian-friendly cath lab. And we had this young lady and with ostium of the left main, super diffuse disease involving everything. And unfortunately, we were guaranteed partially by the extension of the right coronary artery. So we took the time. We did the most significant thing that stabilized the vessel. Sorry, I don't know why I went out. Wow. Let me see what is going on.
Is the battery down, Julio?
No. And I'm clearly connected, but I cannot see anymore my screen. I see your screen and I see you. Can you see me?
Yeah, we cannot see your PowerPoint presentation.
Well, but
So you just stop sharing and then reshare the presentation?
okay, let's try to do this one. So let's go. Okay, let me see. Can you see my presentation?
Yeah, we can see it.
Sorry, I don't know what was going on. I hope it's not coming back. Let's try to make full screen.
It's visible, yes.
Okay, we will see first, stabilize the patients because you cannot do a direct pullback with this unstable situation. So just a simple small balloon pre-dilation and then going to a more comfortable way to the OCT pullback. And then you have in a single shot, very few seconds, the entire picture. So you can see that the content was without any calcium. So you know immediately that there was nothing harder to be confronted. You see how much diffuse were the lipid, the culprit lesion possibly, and then you might acquire immediately the length of the lesion. You might confront the size in this diffuse disease that you might estimate by the lumen that was very constricted compared to the true size that you can read by the EEL. Very important details when you are confronting with diffuse disease. And then you wanted to know about the size of the proximal left main disease because it's a longer segment. And then we discovered that this lady had only the chance to get one single stent. So we decided in line with the request.
Julia, now you are not audible.
Intraluminal results. So measurements are essential, understanding of the content are essential. Then now we are moving to something that is a new coming. So the calcium. Calcium is making an incredible amount of problems today in terms of stent deployment, also with the new generation of the DS. This is the impact on outcome in terms of deaths, MI and TVR, when you are confronting with a mild, with a moderate, and with a severe calcification. So having severe calcification has an incredible impact. Why that? Because angio is not trustable. This is a severe LAD calcification. This is the final results, angiographic results that seems to be very reliable. And then you might see the amount of under-expansion and where is the under-expansion reflecting with the co-registration on your angio. And you can also see the amount of protrusion of the calcify, the nodular calcification through these stents. Why OCT for calcium? Because OCT is reading very carefully the calcium and all the type of calcium. Here you have a few examples when you have a protruding small nodular calcification. Here you have a more deeply calcification. Here you have encircling calcification, and you might measure also the thickness of the calcification. So much, much accurate compared to the other imaging technology. And why is it so important to measure the eccentric, the angle, the length, the thickness? Because the more you have this aspect, the less your stent is going to be expanded. And very, very important is to try to have some fracture. So confronting with a severe diffuse calcification, the first is to try to have, as usually, a pre-procedural assessment, or at least after the small enlargement. And here you can see the amount of calcification along the lesion. You can see how big is the circumferential extension. You can measure the thickness. You measure the loop to be addressed in terms of burr size. And then you can see again. So when you are dealing this way, what you are doing is to decide what to do, rotational atherectomy. Then you can see the effect of rotational atherectomy in smoothing. Then you can go to detect the fracture when you are escalating your therapy using cutting or non-compliant balloon. And of course, in the longitudinal view, you might see the impact in terms of lumen border when you have a baseline rotational atherectomy and after cutting plus non-compliant balloons. Very, very important is to have an evaluation on the way. Here you might see the impact on stent expansion when you fracture compared to when you no fracture and have new tools that might better help in getting fracture. Also, when you have incredible amount of calcification. Here, one example obtained with a shockwave before and after the stent implantation. And we know that these type of tools were recently demonstrated effective and safe for dealing with this lesion. Why talking with about calcium and ACS? Because that is going to create a lot of problem to interventional cardiologists. There's a recent publication showing how many different type of calcified lesions might impact the acute coronary syndrome. And why is important? Because according to the type of calcification, you are making a decision about the type of preparation. And especially this nodular calcification and the calcified nodules are creating problems. Here you have an example that of a patient coming with RCA nappering on the mid of the right coronary artery, almost impossible to cross. The first attempt was a successful attempt obtained by laser and then going to rotational atherectomy. And this is what we got after rotational atherectomy. And so we were escalating progressively from 1.5 to 175 Burr. But here you can see this big protruding mass inside a larger lumen. So you needed to be prepared to upsize incredibly the type of lesion preparation or to use other device. Because if you are not fracturing or making the proper smoothing of these protruding masses, you are going to end up with these apparently beautiful angiographic results, but with this awful OCT result with a large malposition, and of course, with also under-expansion and malposition linked to this nodular calcification. When you are dealing with a super complex cases, there's a case of CTO done in Korea, and this is what we got after the reopening of the vessel. You can see the segment and the content. You can again measure the EEL to be addressed on the type and the size of the stent. So we went based upon these measurements, 3, 5, 4, 0, and then we discovered that there was a clear, large remaining under expansion at the original point of the occlusion. And at this point, it's easy in these patients to have the combination of white thrombus forming when you are underexpanded. So enough to post-deal with a 4.5 balloon to obtain a much better results and to have disappearing the white thrombus. Finally, so also in in-stent restenosis and stent failure, you can gain a lot. Why? Because according to the type of the problems, you can change in your strategy. This is one example of a prior treatment in 2 proximal LAD and cervical lesion. This is the beautiful angiographic results. Lady coming back a few months later with these awful problems. Long left main and then this type of situation. What to do? As I was suggesting before, you scan both vessels. It doesn't matter. You can open up the vessel with a 2.0 balloon, and then you are trying, number one, to understand that the causes of the stent failure. Here you might see how small was the stents in the proximal and in the ostium of the LAD compared to the remaining part of the vessel. And then you are taking also the measurements for distal and proximal EL to know about where to land in the left main and where to land distally and which size eventually of a balloon and stent used. You are doing the same in the circ because perhaps it might be different, but in this case, also we can recognize a very underexpanding stents plus neointimal tissue growing. At this point, you take the measurements again, distal and proximal landing zone, and then you are progressing. And during your intervention, you must start to see something that is teaching you this is a large intramural hematoma going back to a part of the left main. Why is it important? Because it's a long left main. And so you needed to know where to land exactly, where to finish eventually to cover this one. And this is what we got in terms of expansion and in terms of 3D and also the 2D visualization of before and at the end of the procedure. Anecdotal cases, no. This is telling you why and how we work in the last 2 years. On this spectrum of lesion, we target to bring back to the scientific community substantial data. This is Illumin for about 2,500 high-risk clinical, including end-stage patients or lesion characteristics, CTO, diffuse disease, calcification, bifurcation treated with the 2 stents. They were randomized to OCT guidance and angio guidance. The enrollment was finished the 28th of December. What about other type of request? October, bifurcation, major bifurcation to be treated with the 2 stents. October randomized 1,200 patients, left main or no left main bifurcation with a side branch more than 2.5 and need for rewiring a stent during the treatment. Double crash, mini crash, clot. What do you have in mind? OCT guidance versus angio guidance. And what we have done is to try to structure specific algorithm for treatment. Where we are on 25 of February, means 3 days ago, the 1,000 patients were enrolled. So very important. Imaging guidance has more clinical evidence in complex lesion and patient cohort. It's not the fact that we are doing imaging, but it's the correct interpretation, the precise measurements, and the consequent action that makes a difference. Integrated stent guidance with OCT, benefits of automatic measures and angio co-registration. Practical algorithm to apply are made simple by the integration. Larger prospective randomized trial in complex patients and lesion setting with outcome as a primary endpoint are extremely advanced. I was informing you about Illumin 4 in October. I think each cath lab should know how to implement OCT in a more straightforward lesion, having a low threshold for imaging use in complex lesion and patient cohort. Thank you very much.
Thank you, Dr. Giulio, for elegant presentation about the role of OCT for complex coronary intervention. One query about how to predict the slow flow or no reflow phenomena in a patient, and what's the parameter, OCT parameter are there which can predict about this complication during the PCI?
Okay, this is a very legitimate question. And my answer is if you may know the content, you may try to avoid some type of a plaque embolization, especially if you are confronting, likewise it was the lady coming with the left main and diffuse disease. If you might see a full lipid plaque with a lot of tissue, fragile tissue, you can go directly without lesion preparation. When you are starting doing balloon, perhaps you might increase the risk to have some distal embolization. And the same is when you have protruding masses in including thrombus, you may react immediately also by using small molecules like integralins or abiciximab.
So if there is no further comment, let me close this session. I am thankful to all the presenters and the expert panelists for successfully conducting this very interesting session. Let me move forward for the last session. This is about the pharmacotherapy in intervention cardiology, for which the expert panel are Dr. Anil Bansali, ex-head of department endocrinology at PGI Chandigarh, Dr. Sanjay Parada, who is a professor and head department of endocrinology, PGI Chandigarh, Dr. Parminder Singh, he is associate professor in the department of cardiology at PGI, Dr. Bhupender Siag, he is assistant professor in the department of cardiology at PGI. I also invite Dr. Rohit Modi, who is the director of cardiology, Max Hospital, Batinda. He has more than 20 years of experience in the intervention cardiology. Now let me invite Dr. Arun Chopra, a dear friend of mine, to have a talk about DAPT, the newer generation drugs.
Thanks, Dr. Rajesh. I hope I'm audible.
You are audible and slide is visible.
Okay, thank you. Then I'll proceed.
Please.
And in the 10 minutes available to me, I'll try and sum up the data on newer generation DAPT. So DAPT, you know, is a huge field. There have been so many trials. So I'll be only touching some specific issues here. So first is, of course, who needs DAPT? All individuals with acute coronary syndromes need them. After PCI with stents, after bypass surgery, this is quite clear. But now there is upcoming awareness that individuals with chronic coronary syndromes may also need DAPT at times, even though most individuals with stable coronary artery disease don't need DAPT. So among the currently available agents, clopidogrel was the first agent to get approved as DAPT for PCI. And I'll be mainly keeping my talk on patients post-PCI and post-MI high-risk patients. I'll not be addressing CABG patients here. So PCI cure led to the approval of clopidogrel because of significant risk reduction compared to placebo combined with aspirin alone. But there are several issues with clopidogrel in PCI patients. One is, of course, the mild potency of antiplatelet effect. Apart from that, the variable response, the need to undergo two-step metabolism, and a possible interaction with the PPIs has led to several issues. Apart from which, the fact that there is clopidogrel resistance in a variable proportion of the population is another issue, which it was thought led to stent thrombosis and later problems, because of which new antiplatelet drugs were evolved. So two oral antiplatelet drugs came up in the last decade, which are prasugrel, a more potent congener thiropyridine of clopidogrel, and ticagrelor, which was a reversible inhibitor of P2 white valve receptor. The advantage with both being faster onset of action, these act within 30 minutes to 60 minutes compared to clopidogrel, which takes almost 6 to 8 hours, even with the 600 mg loading dose, more predictable response, and no occurrence of resistance to the drug either with prasugrel or ticagrelor. And between these three trials, CURE, Triton, TIMI 38 and Plato, which were all significant, clopidogrel, prasugrel versus clopidogrel versus placebo, and then prasugrel and ticagrelor versus clopidogrel. So these two agents were better than clopidogrel. But the point was that whereas all three trials showed survival benefit from cardiovascular causes, MI or stroke, that means a composite endpoint, all-cause mortality wasn't reduced in CURE with clopidogrel. or in Triton-Timi 38 with prasugrel, whereas Plato did show a significant survival benefit, because of which it became the preferred agent for management of acute coronary syndromes needing either medical therapy, angioplasty, or bypass surgery. But these are some of the questions which need to be addressed, and I'll be trying to address them briefly. Which drug, where, what's the desirable duration, who needs short or extended DAPT, and which are the drugs to be used for extended therapy. So this is now pretty standard. These are the guidelines of ACC, AHA, and ESC, wherein for non-ST elevation ACS, if managed conservatively, ticagrelor and clopidogrel are to be preferred over prasugrel, which is contraindicated. In patients undergoing invasive management, preloading can be done with clopidogrel or ticagrelor and not with prasugrel for this very reason. In post-PCI patients, ticagrelor and prasugrel are the preferred agents, and even though clopidogrel is still approved, these are to be preferred over and above clopidogrel in the setting of ACS undergoing angioplasty. In ST elevation MI, the guidelines are similar. Ticagrelor and prasugrel are to be preferred over clopidogrel. But with fibrinolytic therapy, it is to be remembered that prasugrel has to be avoided for a period of perhaps 48 hours before it can be used. Therefore, clopidogrel and or ticagrelor are the agents which can be used in patients who have been lysed if you wish to load them immediately. However, between these two agents, ticagrelor seemed to be enjoying an advantage until last year the results of ISAR React 5 trial were published, wherein prasugrel not only was more effective, which was to be expected, it's a more potent drug, but also was safer, which led to its upgrade as being the agent of choice for PCI in patients with ST elevation MI or non-ST elevation ACS if they are going for a PCI upfront. For stable CAD, of course, in individuals undergoing PCI, clopidogrel continues to be the drug of choice, and ticagrelor and prasugrel come much lower. The recommended duration of treatment is generally 12 months. But there are some concerns with DAPT duration. There are patients who are at especially high risk of thrombotic events, and there are patients who are at especially high risk of bleeding events. And both of them are pretty commonly found in our practice, and they are often common. They are often the same. So it becomes difficult to choose antiplatelet agents for these patients. Anyway, so this is the ARC guideline for defining who are the patients at high bleeding risk. So high bleeding risk is there if there is one major or two minor criteria are met, and these include, of course, age, baseline hemoglobin levels, any previous history of bleeding, any other bleeding disorders, or need for drugs like anticoagulants or steroids, which may otherwise increase the risk of bleeding. And for these, several trials have tested shorter DAPT therapy duration, which have been generally 3 months or 6 months, but some trials have used 1 month DAPT as well. And on the basis of these guidelines, now it is recommended by ESC that in stable CAD, if an individual is undergoing PCI, then the need of DAPT can be reduced to just 1 month. And if the patient is undergoing PCI for ACS, DAPT can be shortened to 6 months or even in up to 3 months in some select individuals, whereas the standard therapy remains 12 months for all other patients. However, there are also patients who have high thrombotic risk. And these high thrombotic risk factors may include complex coronary artery disease subsets, comorbidities that may be present, and technically complex PCI that have been performed in terms of more stents, longer lesions, or complex anatomy like left main or bifurcation with elective dual stenting. And therefore, DAPT more than 1 year trials have also been conducted, which have largely shown that in such high-risk individuals, there is a 15% reduction of further ACS with the extended use of DAPT beyond 1 year. And in this regard, there is a reduction in cardiovascular death, MI or stroke also. This is obviously at the cause of a increased risk of bleeding, which is why this is not recommended for all individuals with stable coronary artery disease, but only for those who have had PCI and who have high risk features. So if we just wish to simplify what are the current DAPT guidelines after PCI, I think the 2018 Canadian Cardiovascular Society guidelines are simplest. So elective PCI, we decide at high risk of bleeding or not at high risk of bleeding. Minimum DAPT 6 months. If no high risk of bleeding, reevaluate after 6 months. If there are high risk factors, continue DAPT for 3 years. If no high risk factors, change over to single antiplatelet. On the other hand, if there is high risk of bleeding, DAPT for 1 month if BMS, 3 months if DES, and after that change over to single antiplatelet. And in STEMI or NST ACS, increase the duration of DAPT for 1 year, in which again ticagrelor and prasugrel are to be preferred over clopidogrel. After 1 year, again determine the risk of bleeding and thrombosis and increase DAPT, continue it up to 3 years. AF I'll not handle at the moment. These scores are what have been advised by guidelines. The precise DAPT score can be used to determine the risk at the time of stenting, and the DAPT score can be used 12 months after stenting to determine who needs shorter or longer term DAPT. But that is not all, and there are a lot of chronic coronary syndromes. As you can see here, there are 6 chronic coronary syndromes covered in the CCS 2019 ESC guidelines, and they have a persistent thrombotic risk, and they continue to get events over the years, and it's not as if after 1 year or 3 years the events stop. So if we look at these individuals with stable coronary artery disease, those who had a previous ischemic event 1 year ago continue to be on high risk of subsequent events. And the highest risk is actually in those individuals who have polyvascular disease. That means apart from coronary artery disease, they have history of stroke or peripheral vascular disease as well, because of which the concept of dual pathway inhibition has come in. That means along with an antiplatelet agent like aspirin, using an anticoagulant like rivaroxaban, which inhibits thrombus generation, could it prevent further events from occurring in very high risk patients? So in this regard, the COMPASS study has become very popular. A large study with 27,000 individuals compared rivaroxaban and aspirin combination with rivaroxaban alone and aspirin alone, and found that rivaroxaban aspirin combination reduced the primary composite endpoint of death, stroke, MI by about 24%. And this was at the cost of a relatively small number of fatal bleeds or symptomatic bleeds into critical organs. And this benefit was driven largely by a major reduction in ischemic stroke. And this was not at the cost of much increase in hemorrhagic stroke. So if we compare trials in chronic coronary syndromes, the THEMIS trial, which tried ticagrelor, the COMPASS, and Pegasus, which again compared ticagrelor with the COMPASS strategy, we find that even though all 3 had reduction in death, MI or stroke, we find that none of these other trials reached survival benefit in these trials. And it was only the COMPASS study which actually gave a significant reduction in all-cause mortality. And probably the answer lies in this slide. Deepak Bhatt analyzed the data of THEMIS and found that those individuals who had history of PCI had net clinical benefit, whereas those individuals who didn't have history of PCI in stable CAD actually had harm. And this neutralized the benefit of ticagrelor in those individuals. So COMPASS regimen of rivaroxaban and aspirin compares favorably with all other DAPT as regards reduction in MACE and death is concerned. It compares as well with the major new therapies that have come in and which have shown to have significant survival benefit, which is why now rivaroxaban has also entered guidelines as a management strategy for individuals of chronic coronary syndromes with high ischemic or moderate ischemic risk. So this is a strategy which can be considered. After 1 year of STEMI, NSTEMI or PCI, we examine the patient. If there is high bleeding risk, we continue with single antiplatelet agent. If there are additional risk factors like peripheral arterial disease, multivessel disease, or other markers of high risk of ischemic events, we consider these individuals on this pathway. If these are not present, of course, we continue on single antiplatelet. So in these individuals, if they are at high risk of further ischemic events, we check if there is a previous history of ischemic stroke. If yes, then the treatment of addition of choice is rivaroxaban. If the answer is no, then we can choose between low dose aspirin with ticagrelor low dose or low dose aspirin with low dose rivaroxaban. Both these strategies are viable. So to conclude, friends, DAPT is to be individualized. High bleeding or high thrombotic risk individuals need shorter or longer term DAPT, and these categories are now well categorized by guidelines. Dual pathway inhibition is a new concept in chronic coronary syndromes, and the aspirin rivaroxaban combination in these high risk patients appears to be better than classical DAPT because of lesser strokes and lesser bleeding events. A trial is probably needed to study clopidogrel alone for chronic coronary syndromes, which is the safest and cheapest of all the newer drugs. Thank you.
Thank you, Dr. Chopra, for elegant presentation of DAPT in a patient with acute and chronic coronary syndrome. Dr. Parminder, any comment about?
Yeah, thank you, sir, for such a illuminating talk. I think in addition to the selection of the agent, what you have focused is the duration of antiplatelet therapy. That's also very important, particularly after stenting. I would like to know which group of patients you would go for a prolonged dual antiplatelet therapy after 12 months, and for how long, like 18 months, after like 1 year, or for how long?
I think I addressed that issue in the second part of the presentation, but mainly what we have seen is that individuals who have high thrombotic risk, either due to complex coronary artery disease or due to comorbidities like diabetes or CKD, or due to other risk factors like long stents, multiple stents, bifurcation PCI, left main, etc. These are the individuals who need longer term therapy if they don't meet the high bleeding risk criteria. And in them, extended DAPT for up to 3 years is approved.
Yeah, and what about patients like who have once episode of stent thrombosis? Like after stent thrombosis, how long? I mean, do you recommend? Do you give?
These are obviously patients who, it depends upon whether there was a technical problem or not. If there was no technical problem, guidelines are standard for these. But what we would do is that if the stent thrombosis occurred on clopidogrel, we would prefer to add these patients for the next event, prasugrel or ticagrelor, preferably prasugrel, because that is the most potent antiplatelet agent that we have.
Thank you.
Thank you, Dr. Chopra. So let's move to the next presentation by Dr. Inderjit Monga to talk about interventional management of the hypertension. Dr. Monga is currently working as the head of Department of Medicine and the Cardiology at Command Hospital, Chandigarh. He is alumni of the PGI itself, and welcome Dr. Monga to go ahead for his talk on interventional management of second hypertension.
Thank you, Professor Rajesh, sir, for giving me this opportunity. Sir, my topic is today's interventional management of hypertension. Sir, I am audible, sir?
Yeah, you are audible. Yes, you are audible and your slide is visible.
Thank you, sir. Thank you, sir. So, respected panelists, some of whom are my teachers, like Dr. Parminder. Sir, today I am sharing few slides on interventional management of hypertension. Since we all know that hypertension is the #1 treatable risk factor for global mortality, and this is WHO data, which shows that highest deaths are due to raised blood pressure. And diseases attributable to hypertension are a lot many, like heart failure, to name a few: coronary artery disease, heart failure, stroke, cerebral hemorrhage, chronic kidney failure, hypertensive encephalopathy, retinopathy, peripheral arterial disease, aortic aneurysm, left ventricular hypertrophy, myocardial infarction. They all can lead to mortality and morbidity. And hypertension is a silent killer, in the sense that through target organ damage involving the kidneys, it can cause end-stage renal disease, and through LVH and further leading to myocardial infarctions, coronary artery disease, and congestive heart failure, ventricular fibrillation, ventricular tachycardia, and retinopathy, and this thing to the strokes. So they all can cause to mortality. So we know, since we all know the pharmacological management, I'll be covering the interventional management. So coming to the resistant hypertension, where we need interventional management is the strategy is for the resistant hypertension patients. Resistant hypertension patients are when, despite the lifestyle changes and pharmacological therapy, patient's BP is not on target, and despite the usage of minimum 3 drugs, one of which is a diuretic. So these patients come into the category for the resistant hypertension. And important thing is that they all drugs should be at the optimal dosage. So what are the approaches for the resistant hypertension? First, we have to exclude the pseudo resistance. That is by using ABPM to exclude the white coat effect of the hypertension. Then we should minimize interfering substances like NSAIDs, sympathomimetic, and OCPs, and steroids, cyclosporine, cocaine. And secondly, then we should screen for the secondary causes for the hypertension, one of which is renovascular hypertension, that is we'll be covering later. And we should optimize the drug therapy, and we can add on MR antagonists like spironolactone or epinephrine, amiloride or doxorubicin may also be considered. And we can add loop diuretics, that is for CKD patients, and who are patients already receiving potent vasodilator like minoxidil. And if drugs are still ineffective, then we have got two interventional therapies like renal denervation and vasostricture stimulation by the experienced operator. However, if we find that there is a renal artery stenosis, then we can go for the percutaneous transluminal renal angioplasty. So coming to the ABPM, it has got several advantages, that it gives measurements in the real life settings and mean BP over the entire monitoring period, and separately any diurnal or nocturnal variation and nocturnal dipping. And we can also take postural hypertension, and we can evaluate for the resistant hypertension and recognition of symptomatic hypertension also. So ABPM is recommended for diagnosing these patients. And then intervention management, we can have 3 kinds of management in this. One is carotid baroreceptor stimulation, then renal denervation therapy, and percutaneous transluminal renal angioplasty. So coming to one by one, carotid baroreceptor stimulation is the therapy of in which since we all know carotid baroreceptors play a key role in BP regulations. So carotid baroreceptor activation therapy using this kind of a device, which has been done in, it has emerged as a potential therapy for resistant hypertension cases and also for heart failure patients. So chronic electrical stimulation of the carotid sinus nerve via the implantable devices have shown significant reduction in both systolic and diastolic BP. So the trials in favoring this strategy are in RIOS pivotal device-based therapy in hypertension and RIOS feasibility trial. Both clinical and ABPM measurements reduce significantly. So coming to the second approach is renal denervation therapy. Denervation therapy is a catheter-based ablation procedure which is designed to treat the resistant hypertension. Mechanism is by bilateral destruction of the renal nerves traveling along the renal artery by radiofrequency ablation catheters. And Simplicity Hypertension 1, Simplicity Hypertension 2 trials and Simplicity Global History had shown encouraging results. But these were non-sham trials, and Simplicity Hypertension 3 trial, which was a sham control trial with 535 patients, however, had discouraging results. So there was no benefit over optimal medical treatment in 535 patients in 2:1 randomization with renal denervation versus sham procedure. So however, this trial had several study limitations, like patients of African American origin, 25% were included, who respond poorly to renal denervation therapy and respond better to the medical management. Plus, choice of a catheter was also design was also the limitation of this. So we want to overcome this limitation. So earlier generation simplicity catheter system was used, which was commonly used in contemporary practice. But however, this has got several limitations, like presence of single electrode leading to longer ablation time and presence of unipolar electrodes, making selection of ablation site challenging, and it has the inability to ablate deep renal sympathetic nerves due to low frequency power of the catheter. So to overcome these limitations that we saw in Simplicity Hypertension 3 trial, their multi-electrode RF ablation devices have come into picture, like a light hypertension catheter system by St. Jude's and FACC V2 by Boston Scientific, and latest is Simplicity Spiral Catheter System by Medtronic. Plus, some ultrasonic-based therapy have been introduced, like Paradise ultrasonic system by the Ryocor Medicals. So these are mostly multi-electrode catheters which can simultaneously ablate multiple locations at the same time, and results from spiral hypertension of medical trials and Enlighten H1 hypertension 1 trials showed a significant reduction in BP with RDN therapy. So first, Enlighten multi-electrode denervation system. This is a basket-like design catheter, which is so that it can have better contact with the endoluminal surface. These electrodes can have better contact with the endoluminal surface. So initial basket positioning is proximal to the bifurcation, and then it is expanded, basket is expanded, and perform the generator check, diagnostic check for electrode contacts with the endoluminal surface, and then we ablate for 90 seconds. We do minimum 8 ablations, and for second set of ablations, basket has to be collapsed and pulled back, and it has to be rotated and expanded, and ablation procedures again repeated. So this catheter is little bulky. It is 8F compatible, and Enlighten H1 hypertension 1 is the proof of concept trial, which is enrolled 47 patients, and this is in this we found that office BP was reduced by 28 and 10 mercury at 1 month, and these sustained results were seen at 76% of patients at 6 months. So coming to the second catheter, Simplicity Spiral Catheter, which has been still not got DCGI approval, but a few cases are being done in India also, at few centers. This is a multi-electrode catheter with the quadratic vessel contact with for simultaneous ablation of up to 4 using 4 electrodes, and this is a 4F catheter delivered by the guide wire, that is 014, and it is 60-second simultaneous energy delivery is given, and a vessel diameter from 3 to 8 millimeter can be treated, and flexible catheter allows the branch treatment as well. We can go to the distal vessels also, and a 6-inch guiding catheter compatible.
Can you shorten it a little bit here?
Yes, sir. So these were the study design for this catheter sham control trial. So conclusion of this trial was that it is a just proof of concept trial, and it was not a sham. It was the drugs were not used in these patients only. So this is how it works, sir. Simplicity hypertension. This we park the catheter over the O2 wire, and we can go all the branches and give one by one. Same setting, we can do both the denervation for both the sides. So coming to the renal artery stenosis, the second cause for this is the most secondary cause of hypertension. These causes are atherosclerosis and fibromuscular dysplasia. However, less common causes are Takayasu arteritis and dissection of renal artery and others. So coming to the atherosclerotic renal artery stenosis, which is more common in males more than 45 years of age, and it is mostly unilateral but can have bilateral also. And a CORAL trial, however, which consists of 947 patients, however, we tried stenting for these patients, had not shown encouraging results. That has shown that best medical therapy is better probably. And however, there are few subsets of patients whom stenting will definitely benefit are the flash pulmonary edema, severe resistant hypertension, and rapidly declining renal function patients. These were the trials and the most.
Rajesh, will you like to conclude it, please?
Yes, sir. Coming to the fibromuscular dysplasia, this has got different this thing presentation and can be beaded appearance, and hair gradient can be, so we have to measure the gradient before planning any intervention. So just coming to the case example, we have got a 77-year-old.
In that case, you can please skip this presentation.
Okay, sir. Okay, sir. Sir. Sir, so to take home message is patient selection is most important factor for considering the intervention therapies in hypertension, and role of renal denervation therapy is researching in properly selected patients. Based on the current evidence, patients with recent hypertension, no identified secondary cause, maximized on lifestyle interventions and medical therapy may benefit from renal denervation by experienced operators. And ongoing sham trials like spiral hypertension, on and enlightened hypertension, and radiance hypertension will give us further inputs on this. Similarly, renal angioplasty also has got role in selected patients, and especially for atherogenic renal artery stenosis and FMD patients whom GDMT fails, these patients are candidates for renal artery stenting. So that's all, sir. Thank you, sir. Thank you, sir, for giving me this.
Thank you, Indrajit. I think it's quite interesting to see that patients who have got secondary hypertension, they are more responsive to all these interventional therapies. Rather, patients who have essential hypertension, those are the patients who has to undergo RDN, and the response to RDN again depends upon the patient selection. I think most important factor among all these is the proper patient selection.
Yes, sir, true, sir.
Thank you, Dr. Indrajit, and let's go ahead for the next presentation. Dr. Sanjay is going to join us very shortly, so that let me invite Dr. Ambudhar to present his talk on role of ticagrelor for secondary prevention. Dr. Ambudhar is working as Assistant Professor at the Department of Cardiology at Rajendra Prasad Government Medical College, Kangra. Ambudhar, please.
Sir, are my slides visible?
No, you have to share your screen. Kindly share your computer screen. You do have a green button on the downside. Ujjwal, can you help him?
Yeah.
Zoom screen.
Okay. I am pressing it. Then I have to share. No.
So now click on your PowerPoint presentation.
Are my slides visible now, sir?
Yeah, it's visible. Yes, please go ahead. So Ambudhar, kindly restrict to your time of say 8 minutes. Please
Okay,
go ahead.
Good afternoon, everyone. At the outset, I would like to thank organizer for giving me this opportunity. My job is to discuss the role of ticagrelor for secondary prevention. Ever since their introduction, drugs like clopidogrel, prasugrel, or ticagrelor has undergone several randomized controlled trials evaluating their efficacy and safety for reduction of ischemic events, and the trials have compared different durations of these therapy. However, optimal antiplatelet drug, optimal regimen, and optimal duration, which results in maximum reduction in ischemic events without increasing bleeding events, is not known. Based on current evidence, aspirin is cornerstone for secondary prevention, but aspirin alone is not sufficient to provide protection in all group of patients. Ticagrelor is an orally active, reversible P2Y12 inhibitor and has undergone several randomized controlled trials in last few years. The evidence for secondary prevention of ticagrelor has come from various randomized controlled trials, meta-analysis, and real-world experience. Majority of trials have evaluated its efficacy and safety with a duration of less than 12 months. PRATO was the first randomized controlled trial evaluating the efficacy and safety of ticagrelor in patients with high-risk ACS, and it compared ticagrelor with clopidogrel. The results of trial showed that ticagrelor reduces ischemic events with no higher rates of bleeding overall. The trial also showed that ticagrelor was effective in all subgroup of patients, whether patients who were undergoing invasive strategy or those who were undergoing non-invasive strategy. Pegasus TIMI 54 was the first landmark trial evaluating the long-term use of ticagrelor in patients with prior myocardial infarction. In this trial, stable patients with history of MI and additional atherothrombotic risk factor were randomized into two different doses of ticagrelor, 90 mg BID and 60 mg BID versus placebo. The trial and patients were followed up for a mean duration of 33 months. The results of trial showed that both doses of ticagrelor, 90 mg and 60 mg, resulted in significant reduction of cardiovascular death, MI, and stroke. However, there was significant increase in TIMI major bleeding in both doses of ticagrelor, but there was no significant difference in terms of intracranial hemorrhage and fatal bleeding between these groups. In the subgroup analysis of Pegasus trial, in patients with peripheral artery disease, these patients were also at elevated risk of ischemic events, and ticagrelor resulted in absolute risk reduction of 4.1% in these patients. In another subgroup of patients, diabetic patients are also at elevated risk of ischemic events. The event rates in diabetic patients was 5% in placebo groups, and in non-diabetic patient it was 2.6%. So diabetic patients were at elevated risk of events. Ticagrelor resulted in event reduction of 1.1% in these patients. This is pre-specified analysis of Pegasus TIMI 54 trial that evaluated the efficacy of ticagrelor over the study period. The trial showed that MACE events were constant over the study period, and with an annualized rate of 3% in all group in the placebo group. And ticagrelor resulted in reduction of events in all during the whole of the study period during first year and second and third years of the trial, while the hazard rates for TIMI major bleeding was maximal in the first year of the study period. The results from the trial showed that it was the first trial to prospectively prospective study that studied the natural history of patients with history of spontaneous MI on the background of secondary prevention therapies like aspirin, beta blockers, or statin. The risk of ischemic events in patients with previous MI continues for several years. The benefit of ticagrelor for secondary prevention are consistent both early and late after MI and do not attenuate with time. So there is persistent risk of ischemic events, and there is consistent effect of reduction of these events with ticagrelor on long term up to 5 years, because 28% of patients in the trial had a duration of 5 years of follow-up. The two randomized controlled trials, Euclid and Socrates, evaluated ticagrelor in non-coronary atherothrombotic disease. In Euclid trial, patients with peripheral vascular disease were randomized into ticagrelor 90 mg BD and clopidogrel 70 mg OD. There was no significant reduction in the cardiovascular death, MI, and ischemic stroke in the two groups. Socrates trial evaluated ticagrelor versus aspirin in acute stroke and transient ischemic attack. There was no significant reduction of primary endpoints and no significant difference in plateau bleeding in the two groups. So trial concluded that ticagrelor was not found to be superior to aspirin in the prevention of stroke and ischemic events after acute stroke and ischemic attacks. So ticagrelor was not superior to aspirin in non-coronary atherothrombotic disease like peripheral artery disease and cerebrovascular disease for secondary prevention. In meta-analysis by Monica Verdoya et al., evaluated the ticagrelor-based therapy versus traditional antiplatelet regimen in patients with coronary and or non-coronary atherothrombotic disease. 10 randomized controlled trials were included, and pooled analysis of the trial showed that there was reduction of mortality there was significant reduction of mortality in favor of ticagrelor. In another meta-analysis by Wang et al., they included 10 randomized controlled trials, and the dose of the ticagrelor used was 90 milligram BID. The pooled analysis of the trial showed that there was no significant reduction of risk of bleeding or stroke or MI between the two treatment groups, and both therapies were found to be similar. In a systemic review and network analysis by Fenerov et al., evaluated the antithrombotic agents for secondary prevention after acute coronary syndrome. In this meta-analysis, various therapeutic regimens, aspirin, ticlobidine, or prasugrel, ticagrelor-based regimen, showed all reduction in the all-cause mortality as compared to imputed placebo. Whereas when compared to aspirin, only two therapeutic regimens, one at ticagrelor-based and another rivaroxaban-based regimen, showed reduction in the all-cause mortality. But rivaroxaban-based regimen resulted in led to increase in major bleeding. Hence, there was no net clinical benefit with rivaroxaban-based regimen. However, results from real-world experience were surprising. There was in the SCAR registry done by Sebastian et al. In this observational study, ticagrelor was not found to be superior to clopidogrel in patients with acute coronary syndrome undergoing PCI. In another study by Topi et al., patients who were optimally adherent to ticagrelor-based regimen, they had significantly fewer MI hospitalization as compared to clopidogrel cohort. So, optimal candidate for ticagrelor-based secondary prevention. These are patients who have high ischemic risk and low bleeding risk. So, in clinical practice, before starting secondary prevention, one should assess the ischemic risk and bleeding risk of the patient. Since what is the place of ticagrelor in ACC ESC guideline? Since its introduction, ticagrelor has undergone several randomized controlled trials and has achieved class 1 recommendation in various ACS spectrum. In non-ST ACS, it has got class 1 recommendation in patients who are undergoing medical therapy, and in patients who are undergoing invasive management for pre-treatment, it has got class 2A recommendation, and in patients who are undergoing PCI, it has got class 1 recommendation, and it is preferred over clopidogrel. In STEMI patients who are undergoing medical therapy, it has class 1 recommendation, and for patients who are undergoing PCI, it has class 1 recommendation. Ticagrelor has got class 1 recommendation, and it is preferred over clopidogrel. In medically managed patients who with ACS who are not at high bleeding risk, continuation of DAPT based on ticagrelor has got class 2B recommendation after 12 months, and the dose recommended is 60 milligram BID. Why ticagrelor for secondary prevention? It is because of proven efficacy of ticagrelor from randomized controlled trial for its in various spectrum of ACS, long duration, and it has been used to treat wide range of patients and mortality benefit. So take home messages are decision making regarding ticagrelor therapy should be made on case by case basis. Patient factor like comorbidity should be included to calculate the risk benefit ratio, and one should periodically reevaluate patient to determine risk of ischemic event and bleeding risk of these patients, and these patients should be followed up periodically to look for a sustained effect of these therapy in follow-up. Thank you.
Ambuda very nicely summarized the role of ticagrelor for secondary prevention. Will you like to comment something about its role as a monotherapy in post-PCI patients?
In post-PCI patient, two trials, Twilight and Global Leader trials, they have evaluated role of ticagrelor as monotherapy. In these patients, they post ACS, post PCI patient, after 3 months of ticagrelor and aspirin, these patients were randomized to ticagrelor monotherapy, and in toilet trial, it has been found to reduce major bleeding events significantly. But in global leader trials, it was not found to be superior. So still, there is need for dedicated randomized controlled trial to answer this question. But based upon current evidence, we can say that it can be recommended as monotherapy after 3 months.
Thank you, Dr. Ambudar, for your precise presentation on the ticagrelor therapy for secondary prevention. And now let me invite my childhood friend, Dr. Sanjay Badada, with whom I had done my MBBS course. Sanjay is head of department head of department endocrinology at PGI Chandigarh, and he is going to talk about SGLT2 inhibitor and heart failure. Sanjay, please.
Yeah, thank you, Dr. Rajesh, and the organizing committee for this opportunity. And myself, Dr. Rajesh and Parminder, we are from the same college, we are the same alma mater, and thank you for the opportunity. So, my slides are visible, Dr. Rajesh?
No, you have to share your slide.
Just a minute. Just a minute. Yeah, so now it's visible. Hello.
It's still not visible. Yeah, it is visible now. Sanjay.
Okay. Thank you. I think it is the last talk of the day.
Yes.
But I've never.
It's a very important one as well.
It's very important, and it is important for us also, because what the cardiologists think about the SGLT2 inhibitor. The topic of talk is that SGLT inhibitors and the heart failure. So this is very nice publication from Lancet, and the war against heart failure, the Lancet lecture. So on the left side, you can see that there is a reduction in the myocardial infarction from 2010, and it is equally reduced the prevalence of myocardial infarction in the male and as the women. But on the right side, you can see that clear cut there is a progressive rise in the prevalence of heart failure. So meaning by that, on one side probably cardiologists are very active and they are fixing lot of arteries and the myocardial infarction is reduced. But at the same time, they forgot to take care of the heart failure and the heart failure is increased significantly. So what is the relationship between heart failure and diabetes mellitus? Diabetes and heart failure are risk factors for each other and promotes each other, you can say. Type 2 diabetes patients have approximately 2.5 times higher risk of developing heart failure than non-diabetes patients. A very interesting observation is that 1% increase in HbA1c is equivalent to 8% increase in heart failure, meaning by that glycemic control plays very important role to reduce the chances of developing heart failure. And nearly 40 to 50% of patients hospitalized for heart failure have diabetes mellitus. So probably endocrinologists also should play a very proactive role to reduce the prevalence of heart failure in hospitalized patients. Now coming to the drug, SGLT2 inhibitors are found to be beneficial in diabetes mellitus since it reduces the HbA1c. So I'm sure it will be should be helpful for the heart failure also. So we are going to discuss about the SGLT2 inhibitor and heart failure with this background. So here is American Diabetes Association Guideline 2021, and it is very clear. One thing about that is that particularly the heart failure is there, and if it is, that is also heart failure with reduced ejection fraction. So LV ejection fraction is less than 45%. ADA says the treatment of choice is the SGLT2 inhibitor. On the left side, you can see further in ADA 2021 guidelines that if ASCVD is there, then you can use GLP-1 receptor agonist or SGLT2 inhibitor, either of them. But if there is heart failure is associated with reduced ejection fraction, then preferred drug is the SGLT2 inhibitor, and probably this thing one of the mind in the organizers, and that's why we are talking about the SGLT2 inhibitor and diabetes mellitus. So number of SGLT2 inhibitors are available in the Indian market, and these are like empagliflozin, canagliflozin, dapagliflozin. These three important ones are available in the Indian market, and you look at it this in randomized control trials that 3-point MACE is reduced with the empagliflozin as well as canagliflozin. Any cause death is reduced with the empagliflozin, the EMPA-REG outcome trial. But interestingly, if you look at the heart failure, then you can see all the SGLT2 inhibitors are effective to reduce the heart failure. So we can say from this slide is that the benefits of SGLT2 inhibitors are consistent across all the drugs of SGLT2 inhibitor irrespective of the doses. Now coming to the very interesting study, that is DECLARE-TIMI study and heart failure. So the DECLARE-TIMI study said where they use the dapagliflozin, and they says there is 17% reduction in the composite of CV death or heart failure hospitalization with the dapagliflozin. Now very interesting is that dapagliflozin prevent heart failure consistently regardless of the baseline CV disease is there or not, heart failure is there or not, ejection fraction is normal or reduced, or the kidney function is normal or reduced. So this particular slide is clearly mentions that, or the giving the message that dapagliflozin can prevent the heart failure irrespective of the baseline condition. Another study with the dapagliflozin and comparing the CANVAS study and EMPA-REG study. In this particular slide, what I am trying to convey the message is that dapagliflozin, in the study of dapagliflozin, there is primary prevention of 60%, while in case of CANVAS trial 34%, while in case of EMPA-REG 1%. So the individuals in these all three trials, like in CANVAS and EMPA-REG, the patients are having mainly ASCVD, established ASCVD was there, while in case of DECLARE trial, the baseline established ASCVD was just present in the 40%, 60% of patients were having the non-established ASCVD, meaning by that these gliptins are effective if a established ASCVD is there or ASCVD is not there. Although the information from the CANVAS and EMPA-REG is not available, but DECLARE trial clearly says that you can use as a primary prevention as the secondary prevention with these SGLT2 inhibitors. Very interesting study by the John McMurray that dapagliflozin in patients with heart failure and reduced ejection fraction. So this is a large study. Approximately 5,000 patients with heart failure were enrolled in this study, and ejection fraction was less than 40%. Dapagliflozin used in the dose of 10 milligram, and in this the baseline data of the 42% of individuals had diabetes mellitus, and 3% were newly diagnosed diabetes mellitus, while remaining patients were not having diabetes mellitus. And looking at the primary composite outcome, and you can see that primary outcome is reduced by 26%, hospitalization for heart failure by 30%, death from cardiovascular causes reduced by 18%, and death from any cause is also reduced by 17%. So you can say the primary composite outcome in this particular study was very good. And interestingly, this study also clearly documents that irrespective diabetes is there or not, these drugs are effective, and there is effectiveness in reduction of the hospitalization of the urgent heart failure is approximately 25 to 27%. Now let's look at what are the possible mechanisms of pleiotropic benefits of the SGLT2 inhibitors. We all know that SGLT2 inhibitors reduces significant weight, so weight loss is an important. Smart diuresis, therapeutic ketogenesis, or the superfuel theory. I'll talk briefly about that in my subsequent slides. It improves endothelial dysfunction. It inhibits the sympathetic nervous system activity. It improves the myocardial bioenergetics. It increases glucagon, and that's why it causes inotropic effect and reduces oxidative stress. So in addition to these mechanisms, few more mechanisms it SGLT2 inhibitors act are the it reduces the preload. In the cardiac language, it is you can understand better. It improve in cardiac metabolism and bioenergetics. It inhibits the sodium hydrogen exchanger, so that plays an important role in the metabolism, and it reduces the central sympathetic tone, and it is also having clearly benefit on the renal effects. So as I mentioned that SGLT2 inhibitors versus loop diuretics, I will say SGLT2 inhibitors are smart diuretics. In the figure A, you can see that interstitial edema is there and the lumen also has widened, meaning by that intravascular as well as interstitial fluid is more. B is showing SGLT2 inhibitor, and you can see here that sodium in loop diuretic as well as with the SGLT2 inhibitors remains decreases. The interstitial volume also decreases with SGLT2 inhibitors as well as with the loop diuretics. But the last panel, you can see the intravascular volume is reduced by the SGLT2 inhibitors, but significantly reduced by the loop diuretics. And in this figure, you can clearly observe that loop diuretics reduces significant amount of the intravascular volume, though SGLT2 inhibitors also reduces, but it reduces up to a certain limit, and that's why the SGLT2 inhibitors are called the smart diuretics, and that is responsible for reducing both interstitial volume as well as intravascular volume. Now coming to a word about the superfuel hypothesis. The superfuel hypothesis says that in type 2 diabetes heart, there is an increased fatty acid oxidation, decreases glucose oxidation, and there is decrease in the phosphate to oxygen ratio, and cardiac work efficiency reduces. That leads to reduction in the myocardial contractility, and that finally culminates into increased incidence and progression of the heart failure. Now, if a patient will start on the SGLT2 inhibitor treatment, what happens? There is reduction in the fatty oxidation as compared to the type 2 diabetes heart without SGLT2 inhibitor. There is increase in the level of beta hydroxybutyrate, and there is increased level of the ratio of the phosphate to oxygen ratio, and that leads to the increased better oxygen utilization. And all these ultimately leads to increased cardiac work efficiency, increased myocardial contractility, and reduces the incidence of and progression of the heart failure. So according to superfuel hypothesis, the ketone bodies formed by the SGLT2 inhibitor, and that is responsible for the better utilization of the energy in a patient of type 2 diabetic heart. A word about the NHE, or that is the sodium hydrogen exchanger. So you can see in the left side that is a normal situation where the NHE sodium hydrogen exchanger takes the sodium inside, and this one sodium inside, there is opening of the sodium potassium channel and potassium enters here, and also it helps to take the calcium inside the cell, and this calcium once inside the cell, it inhibits the metabolism in the basically mitochondria. So if we use SGLT2 inhibitors, it blocks this NHE1, so there is less sodium is entered here, and less sodium is available to open the sodium potassium channel, so it won't open, and same time it also there is sodium is less, so less calcium is also entering into the intracellular space, and the less calcium is available, and the mitochondrial energy utilization is appropriate. So it has a significant effect on the NHE, and that is responsible for the better energy production or phosphate to oxygen utilization. In addition to that, we know that brain can use the ketone bodies as energy, and SGLT2 inhibitors is also called a pharmacological starvation. The term used for the SGLT2 is it causes pharmacological starvation, and that causes the mild ketosis, and this mild ketosis indeed acts on the heart, that is the pump, acts on the pipe, that is the vessels, and acts on the filter, that is the kidney. So at all three sides, pipe, pump, pipe, and the filter, that there is a reduction in the sympathetic outflow at all places, and that is good for the reduced sympathetic tone. We know that is very good for the heart and the remaining organs also as well. Now coming to the SGLT2 inhibitor and cardiac effects, we all know that SGLT2 inhibitors establish the tubuloglomerular feedback normalizes, and that leads to decreased cardiac preload, decreased cardiac afterload, as well as decreases LV remodeling. Because of all three factors are responsible for plays an important role in the heart failure, and the SGLT2 inhibitors targets all these things and prevents the heart failure. Second last slide of my presentation, and you can see the SGLT2 inhibitor fixes the pump, pipes and filter, as I mentioned previous slide also. So you can see in this particular slide there is a pyramid, and in which it says diabetes and the multiple risk factors. Upper part of pyramid is diabetes and established CVD, and here is the primary prevention of the population, here is the secondary prevention of the population. Here these three arrows are there going from up to down. So you can see that for the renal protection and for the hospitalization of the heart failure, SGLT2 inhibitors are effective for both the condition, for the primary prevention as well as for the secondary prevention. While in case of major adverse cardiovascular events is useful in case of the secondary prevention only, not for the primary prevention. So it is clear that SGLT2 inhibitors fixes all three: pump, pipe and the filter. So I end my presentation over here by saying that diabetes is an independent risk factor for the heart failure. Heart failure is an early complication of type 2 diabetes with significant morbidity and mortality. For cardiologists, for endocrinologists, when choosing an anti-diabetic drug, the impact of heart failure merits consideration. And I can say with confidence with the available literature that SGLT2 inhibitors are most favorable among all the available anti-diabetic drugs on cardiovascular outcome, and with reference to the heart failure. Thank you very much for this patience hearing. Thank you, Dr. Rajesh, Dr. Parminder and organizing committee for this opportunity. Thanks.
Thank you, Sanjay, for a very precise presentation and making all the doubt clear about SGLT2 inhibitor for cardiovascular practice. We as an intervention cardiologists are less informed about this newer drug therapy, which is very much effective in decreasing the cardiovascular morbidity and also the mortality. Your comment about the pharmacological starvation is something impressive. Instead of we asking the patient to have a dieting or intermittent fasting, your concept about say pharmacological starvation, at least in those who are diabetic, is something very beautiful. And let's start the practice of using SGLT2 inhibitor in at least diabetic patient who do have both LV systolic and also the diastolic dysfunction.
Yes.
Parminder, please.
Thank you for such a, you have answered most of the questions which I had in my mind before your presentation. I would like to ask just one question.
Yeah, please.
From practical point of view, like before starting, as they induce ketogenesis, right?
Yeah.
So what are the precautions before we start with these drugs in cardiac patients having diabetes or without diabetes for precaution?
Thank you, Dr. Parminder. I am sure that you convinced that you will prescribe the SGLT2 inhibitor, and so this very question, practical question, that what to look for that. So what I say is the first and most important thing is that we should calculate a eGFR. So of course it can be given up to the 30% eGFR, so no problem. Second most important question is that it causes the urinary tract infection. So what we do in our clinical practice is we ask a patient to get a urine routine microscopy before prescribing SGLT2 inhibitor, or at least we'll inform the patient that you drink lot of water, means well hydration is required. Maybe lot of water for the problem for the cardiologist because of heart failure and all, but you can say adequate hydration. And if patient have any symptom related to the UTI, they should stop the drug and report to the doctor. So that is one important thing. Now regarding the ketogenesis, and Dr. Rajesh was telling, and I was also telling, pharmacological starvation. So the ketone body level is increases, but it does not increase that high that cause any decay or some problem. But it has been observed that one of the side effect of this SGLT2 inhibitor is euglycemic decay. So we should know that the patient can have ketosis even the blood glucose is not very high. So you keep in mind one of the side effects, and should not reduce the insulin doses very drastically. That is another message, because if the insulin deficiency is there and it increases the glucagon, so there is alteration in glucagon to insulin ratio, and that can lead to the euglycemic decay. So should not reduce the insulin dosage very rapidly and make adequate hydration. These are the few important practical points for before prescribing SGLT2 inhibitors.
Thank you so much. Yeah.
Thank you.
Thank you, Sanjay, for a wonderful presentation. And I thank you all. At the end of this 2-day CME, let me have a concluding remark. We had a successful 2-day CME, which was attended by about 300 attendees and around 40 national and international faculty members who actively participated in this scientific meeting. It was a pleasure and honor to have the collaboration of this meeting with the FSCAI USA. I hope the CME would have helped all the participants with a robust scientific knowledge. My heartfelt gratitude to all of you for your kind support. I sincerely appreciate your presence and the active participation in the CME. I'm thankful to my all fellows, colleagues from the Department of Cardiology, Advanced Cardiac Center, PGI, for extending their support for this beneficial cause. This mutual interaction with all the fraternity was really outstanding. A big thank to all the eminent international faculty, including Dr. Akasaka from Japan, Florian Kukli from Europe, Elvin Keddy, and Dr. Galio, and all the eminent national faculty who took their precious time to grace this program and actively participated to make it a grand success. Few of my dear friend and professional colleagues, Dr. Swami, Pratap, Dr. Chopra, Dr. Praveen Chandra, Anil Dal, and Ankush were always there with me for any scientific work. A big thank to all of them. I'm also thankful to Dr. Sanjay and Dr. Bansali from Department of Endocrinology who has extended their support for this cardiovascular CME. Industry support is always play a pivotal role in carrying out such a scientific program successfully, and therefore I would like my thank to all the industry partners for dedicating their time and effort to make this program successful right from conception till conclusion, including Torrent Pharmaceutical, other organizations who lead their support to this novel cause. A special mention and thank to entire team of Abbott Vascular who actually became the backbone of entire back office operation and arrangement with all the precision till the last minute. This educational activity was conducted under the banner of World NCD Federation, which is a committed society towards spreading the awareness for addressing this global epidemic of cardiovascular disease through their kind educational seminar and CME. A special and heartfelt thank to my PA, Mr. Amit Kumar, whose hard work and secretarial help could make the meeting very successful. And at a last, I'm highly thankful to Dr. Ganesh, my senior research fellow from Department of Cardiology, who gave me an uninterrupted 24/7 support for the scientific content and smooth conductance of this CME. Thank you all for joining this CME. Thanks, everyone.
And thank you, sir, for organizing such a nice meeting. Thank you so much.
Thank you. Thank you. Thank you, Sanjay.
Thank you, Rajesh. Thank you.
Thank you, sir. And Dr. Bansali, thanks for joining us.
Yeah.
Okay. Thank you. Let's.
Okay, Rajesh. Thank you. Thank you, Pramod.